Okay, has anyone not signed in yet? Oh, you're about to. Okay, thanks, Carson. All right, we're gonna go ahead and get started. First, I forgot to introduce us, so I'm gonna do that. My name's Verena. Me and Zara, who is printing right now and will be here shortly, are co-directors of GCC. And yeah, we have our other wonderful leaders here. Megan, do you want to introduce yourself?
Hi, I'm Megan. I'm one of the two enrollment coordinators. So Dorian might be joining us in a little bit. He's the other one. We're the people that you see when you're in clinic, leading clinic.
And I'm Annika. I'm the training coordinator.
There's also one other training coordinator. And then we also have our outreach coordinators, which I don't know if you guys know them, but it's Justin Wing, is that correctly? And Crystal, I don't know if this is last name. But yeah, if you guys, because I know some of you are HPM, and we have a lot of HPM people in SHAC GCC. So you might see some like familiar faces and names if you are. But I'm not HPM, so anyone that isn't, you're with me. Okay, so what we're gonna start off with today is like general overview of what your role will look like and like what it means to be a certified application counselor, which is what you're all here to train for. So yeah, let's go ahead and dive into things. First of all, an explanation of what SHAC is. SHAC is an umbrella term for a lot of branches. Get Covered Carolina is just one of them, but SHAC, which stands for the Student Health Action Coalition, it has a lot of different components to it, and the whole purpose of it is to provide free healthcare and services to underserved populations in our local area. And it's like completely composed of students, which is the really cool aspect of it. And so you see a lot of different types of students. So we have like in the med clinic alone, there's like pharmacy students, ophthalmology students, just like all of like the medical students that you'll be able to like interact with and stuff. There's a bunch of different people from that are helping out in different ways. So yeah, it's a very interdisciplinary team, and it serves like a very like general purpose about like providing healthcare to our community and stuff like that. So yeah, that's SHAC in general. And then we have Get Covered Carolina. Oh, we already did that. We have Get Covered Carolina, which is one branch within it. And our role is basically to inform patients about health coverage, discuss like health coverage options with them, and help them basically navigate what can be a very confusing system, which is the healthcare system, in terms of like insurance and everything like that. And what that also means is like familiarizing ourselves with not only like marketplace, Medicaid, all those things that we're going to talk about today, but also local like community resources. So we like volunteers to be pretty familiar with what's like available locally. So we're going to talk about things like UNC Financial Assistance, which is a way of reducing costs at UNC facilities. We're also going to like familiarize you guys with resources outside of that, like connecting patients with sliding scale clinics, the health department, things like that are also very important to our role because we're just there to like help in any way we can, basically. And this is something we're going to say several times throughout today, but you're going to think like, oh, this is a lot of information. There's like no way I'm going to be able to know everything about health insurance. That's not the expectation. The expectation is just that you guys are there and want to figure out how you can best help them. Like we're like, Zara loves to say that we're like expert Googlers, which is very much the case. Like you're not going to be able to like know every detail about the healthcare system, but you need to want to figure them out for the patient, so that you can like help them in their journey to like getting coverage. Another thing too is I'm using the word coverage on purpose because sometimes getting reduced healthcare doesn't always come in the form of insurance necessarily. Coverage is a more like general umbrella term that we're going to be using to encompass not just like an insurance plan, but all the different ways that you can reduce the cost of different healthcare services. So yeah, that's like an overview of what you will be doing as a certified application counselor. As far as like this specific role goes, this is something that is through the Center of Medicaid Services, which is why you guys have to complete those modules and everything. So it is like a distinct role through their like entity, but like since we're working with SHAC, we have a much broader roles and responsibilities that I just described. And yeah, this is just, again, repeating everything I just said. A lot of our role is just, wanting to understand coverage options, educate patients on coverage options, and really, really try our best to connect them with the best resources that we can based off of the information that we have. That's really the biggest goal here. Let me look through this, see if I want to emphasize anything. Yeah. Okay, sorry. So we're gonna start off going through health insurance basics. So these are all terms that were covered in the modules. If you haven't been able to progress through the modules yet, that's okay. Hopefully you're in a group with someone that has at least made somewhat of a dent. In which case, please try and explain to fellow group members what you were able to pick up from each of these terms. We're gonna go through them and explain them in detail. But talk to each other in your groups right now about the definitions for each of these terms. And dang it, you're supposed to write this on your worksheets, but they're not here yet. So just think about it for now, and then the worksheets will be coming shortly. Okay, and we'll walk around and answer questions. You definitely got the list. What were you able to find? Do you remember anything? It's okay. So deductibles are a little bit different actually. So the reason they're grouped in premiums here is because it's a characteristic number of the plan itself. So it's not service-based. Your deductible is the before your insurance even starts kicking in. So let's say my deductible is $1,000. I have to pay $1,000 out of pocket before my insurance will start kicking in. Wait, say that one more time. Exactly. That's exactly what the deductible is. That's the most simple way of understanding it. It's I need to pay $1,000 before I even basically have an insurance. Yeah. So that's the deductible. But what you mentioned, the service-based stuff, that's going to be your copayment commercial insurance. So that's going to be, it's a $100 copay for X service. That's that. And then out of pocket costs, those are similar to what you just described, because out of pocket costs, that's just referring to anything I'm having to pull out of my bank account to pay for this service. So that's a more general term. And then do you guys have a guess what this means? Or your the loans. Yeah, exactly. What about premium tax credit? Is that a good thing? It's a good thing.
Lower monthly payments for your insurance. Maybe information
So yeah, well, even more generally, tax credits are just discounts. They're just discounts on your insurance plan. So premium, that's for premium tax credits, but it's a usage cost. So I don't know, let's say it's supposed to be $200 premium per month. I have a premium tax credit that covers a certain amount of that. I think depending on my income, bring that to as low as $0 or dollars or something in that range. So the premium tax credit will vary depending on how much you're bringing in, and then we decide how many discounts you qualify for.
So,
and then
the amount that you pay for stuff like
yeah, and now you'll know that. Yeah, and we really emphasize understanding executive well-being and employment well, but then a lot of, I guess, is like educating patients, so, you know, even if we're not so the mold is sometimes we want them in insurance. That's like, it's like knowing what, all this stuff means, like, it's a lot of, it's very, they make it very fun to understand for reasons I will never understand. So a lot of our work is, everything is explained to you so that they feel confident having they go out and see how much pay or yeah, knowing these definitions here. There's not a lot of it to memorize, stuff you have to memorize. It's very, very key. Do you guys have any questions?
It's like.
So right now we don't have a minimum membership requirement, we have a maximum, so that everyone's able to get to the clinic. We can only do every other week. So we have that maximum place, we don't have a minimum right now, just because we have like pretty large cohort involved. Usually it's the opposite problem where people have trouble getting into the clinic since there are people don't have trouble getting in the clinic, that's not what I say, but we have to make sure everyone has enough shifts available. So those are only an issue. Those, we're gonna talk about it, shifts happen weekly, so we have, they don't have multiple clinics though that are happening every week. So we have our medical clinic, which is Wednesday nights, and then we have CEX, which that's on like Tuesday mornings, or yeah, Tuesday. So we have like multiple opportunities to get. Yeah. We also have a virtual. We'll talk about all of that once we get past the like. Anything about like this? Yeah, we'll talk about it. Don't worry. The issue is like usually not the exact same for everyone, so we'll have to talk to you guys individually about it. And yeah, we'll figure out when it's best to do that. I know, it's we had like people last semester in a similar thing where like they just kept calling, we're connected to someone else and connected to someone else and no one helped them. So we have like ways that like more ways that you can try. I have like maybe some potential emails that work to contact from last semester, but yeah, we'll discuss it like individually.
Yes.
What's up, guys?
No, I just feel like Jerry asked. I was oh, really?
Yeah. It's very, we're like, okay. He doesn't know like the pricing counts for and so now it's like unintentional insurance undergrad and non. Yeah, then you're gonna go to your average. So from like private employer coverage and then if you like all that categories. And then yeah, yes.
Have we, what are we looking to on like
After.
Yeah.
Yeah. So then you're.
I consider it as individual. Okay. Yeah, I'm just gonna put it in my update winner.
Yeah.
Oh, yeah. To make sure we're like.
It is. Yeah. That's the whole thing. And there's like other things that.
I was so many reasons. Oh, yeah.
We'll have it because we're gonna do that. Okay. Yeah. All right, guys. We're gonna bring it back in and discuss all of these terms. Hopefully you guys were able to like get through all of these in your groups and discuss definitions of and everything. But actually, before I move to the next slide, who wants to define health insurance and health coverage for us and explain the difference, which I already explained earlier? Anyone at all? I already gave you guys the answer. Okay, Carson, all you. Hmm. Yes, that was a perfect definition. Exactly. So yeah, health insurance is going to be between the individual and some like health provider entity, some company that is offering them these benefits of coverage. Health coverage, like I said earlier, and like Carson just explained, is a much more general term, encompassing, you know, any way that that a consumer is able to reduce costs for their coverage. What's up? Yes, these slides will be shared, and I'm currently recording this session right now, so you guys will be able to look back at both. Yeah. And then the next one was in-network versus out-of-network. Does anyone know what that means? Anyone want to take a stab? If you're wrong, that's okay. What's up? Yes, that is also exactly correct. Why is I feel like there's supposed to be a slide with that definition. It's okay, we can just talk about it. Yes, that's correct. In-network is going to be those preferred providers for a certain plan. And so the costs of services that you would have to pay for in-network providers are lower than out-of-network providers. So it's literally that straightforward, and that's laid out in something called the summary of benefits, which we're going to talk about earlier. So yeah, you have in-network and out-of-network providers. What about premiums and deductibles? I know you guys talked about it. Yes, perfect. And then what about a premium? Do you know what that one is? Yes, yes. So yeah, your premium is your monthly payment. So each plan has an associated monthly payment with it. And this is something that like doesn't change. Like your premium is it's the same cost every month. The deductible is exactly what you just said. It's the minimum amount that you have to pay out of pocket before your health coverage starts kicking in. Give me 1 second to pull something up. Let's see. Okay, here they are. Okay, yeah. Okay, I found the slides, guys. So yeah, this one is the one that we just talked about, the network being the list of doctors that you're required to use to get coverage, and then in-network and out-of-network is what we just described. So the in-network is what the preferred providers that your insurance plan will actually be able to like reduce your costs for. Out-of-network is the services, like any services you receive from them, your insurance won't cover because they're out of network. So it's very straightforward. And then with the premiums and deductibles, It's again, the premium's the monthly amount that must be paid. We always compare it to like a subscription. So it's like, your Spotify subscription, it's like $10 a month. Your premium is going to be like, I don't know, $100 per month. It's like that constant payment. And then the deductible, once, let's say my deductible is $1,000, I have to pay out of pocket, like completely my money, $1,000 before my insurance starts kicking in. Do you guys have any questions about those terms? Anything that's confusing about them? Okay. Yeah, and then these little graphics on the right, this one's for the premium. And it makes a good point here. So yeah, premiums aren't always perhaps monthly payments. Other plans can charge like quarterly or yearly premiums. So in the same way that a subscription isn't always necessarily a monthly payment, premiums can be at different intervals too. And then the deductible, oh, it used the same number example as me, $1,000. She has to pay that before her insurance starts kicking in. Co-payments and co-insurance. Anyone want to try and define those before I move on to the next slide? Yeah.
Payments. Set amount that you have to pay. Go to a doctor's visit or get like medication or anything like that. Co-insurance is gonna be a set percentage of an amount. So like if it was 100, your co-insurance can be 20%. So you pay $20.
Perfect. Yes. Your copay or your copayments or your copay are fixed amounts that you pay for a covered healthcare service. So for example, let's see which example is used here. So whenever Kate goes to get her medicine, she pays her plan's copayment of $15. So that's a fixed $15. Whereas coinsurance, which should be the next one, this is going to operate based off of percentages. So instead of Kate paying a fixed $15, it's going to be Kate pays like 20% the cost of a certain service. So here she's paying 20% for a $100 test. So she's going to have to pay $20 and then $80 are going to be covered by insurance. Does that make sense, the difference between those two terms? Okay. Yes.
Is this all after the is that
It paying the co-payments and the co-insurance. What aspect of it do you mean? Like, oh, like before you meet the deductible, are you paying 20% or are you paying 100? Yes, yes, yes.
A lot of insurance plans, like you'll see like in the summary of benefits and stuff, you'll see like what they'll cover. A lot of health insurance, and you probably relate like with your parents, actually will pay for it like before deductible happens if it's like routine care, like if you're going to like your yearly physical or like, your primary care doctor, you'll just have like that $40 co-payment or whatever. So that is one note, is that a lot of plans won't have that, whereas other plans will not pay anything until you meet that deductible, so you just have to look at that.
Yeah, so it definitely depends. And that's why we're going to talk later about the summary of benefits, which is going to be a really, really important document for explaining all of these things for that specific plan. What's your question?
So like if you have a $500 deductible, you go to a doctor's visit, that's $300.
For the situation that Megan described, where your insurance plan states beforehand, I'm not paying that until you meet your deductible. She was saying there are some cases where that's not the case, where they'll say you can pay the 20% or whatever before you meet your deductible. And so that's going to be outlined in the specific insurance plan. Yeah.
And a lot of preventative services are like before the deductible.
Yeah. Mhm.
If there's like, if it's like insurance plan, the company we just got billed.
So you're saying in the situation where it's the first one where you only have to pay your copayment even before you meet your deductible, is that amount you pay out of pocket going towards your deductible? Is that your question?
Like the other situation, sorry.
Okay.
It's that.
So in the other situation, then you will have already met your deductible before you start paying these. So up to that point in the other situation, you would have been paying out of pocket for all of these services. So by the time that you're at the point where you're paying a copay or a co-insurance, you'll have already met your deductible. So that's like out of the picture. Does that make sense? Okay. All right. Awesome. And then these are more general terms. So out-of-pocket costs, I've already been using that term multiple times. It's just referring to the consumer medical expenses that aren't reimbursed by insurance. So literally just the name, out-of-pocket costs. It's something that you're paying for. And then your out-of-pocket maximum, it's the most that you're going to have to pay for medical services. So at this point, after this, the insurance company is paying for all of your further costs. And this is really important, this doesn't include the premium or out-of-network services. So even after you meet your out-of-pocket maximum, you're still paying your like quote unquote subscription fee. That fee doesn't go away, and neither do out-of-network services, but everything else will. Let's see if this is a helpful graphic. Yeah. Do you guys have any questions about that?
It says for out-of-pocket maximum, this amount doesn't include premium. By premium, do you mean stuff that isn't medically necessary?
No, your premium, we'll go back to the slide that has that, is the monthly amount that you pay for a health insurance plan. Yeah. So the premium is always, that's the term that's always going to refer to that monthly or bi-monthly or whatever fee, the regular payment that you provide to pay for your insurance. So yeah, you're going to have to keep paying that even after you meet your out-of-pocket maximum. And then premium tax credits, those are really important. So I'm going to have someone try to define them before I move on to the next slide. Anyone want to give it a shot? Yes, Kendall. Yes, so premium tax credits, yes, they're basically discounts that lower your costs. You don't necessarily need to have a silver plan to have a premium tax credit. Premium tax credits are based off of income, so you have to be between 100% and 400% of the federal poverty line. But that's exactly right, that it is the way of reducing costs of your premium. That's why it's called a premium tax credit. It's a refundable tax credit that helps individuals with lower moderate income afford health insurance. And yeah, like I said, there is an income minimum as well as an income maximum in order to get these discounts. And it's literally is just a discount. So in here, it says Kate qualifies for a premium tax credit that helps lower her monthly premium down to just $82 a month. If her premium was originally like $386 or something like that, and it's the premium tax credit literally just works as a discount to where it brings it down to $82 depending on your income. Does anyone want to explain why you think there might be an income minimum for premium tax credits? Because I think this is a confusing point for some people. You would think that like the lowest income people should be the ones qualifying for this, but you do have to make a minimum amount. Nikki, what do you think? Yes, exactly. So a lot of this comes down to allocating government resources efficiently. And so those people below 100% FPL should theoretically be applying for Medicaid. And so they have these separate marketplace requirements. And marketplace, we'll define that later, is just referring to how we're going to get these insurance plans, which have all of these characteristics. Okay. Why is $20,783 the critical value? This also is a critical value that changes quite frequently. Yes. Exactly. That is the federal poverty line. So all of this 100% FPL, 400% FPL, all of that's referring to a value relative to the federal poverty line. And that's how all of these income requirements are defined. They're going to be based off of whatever number the federal poverty line is set at for that year. Yeah. Any questions about premium tax credits? Yes. Absolutely, yes. Household size is huge. We're going to talk about this. So you can't, these numbers, like the federal, they really mean nothing unless you know how many people they're divided across. Because if I'm making $20,000 and I'm only using that money to pay for my own expenses, that's very, very different than making that amount and having 4 kids. So that's why household size is going to be a really crucial thing to ask patients in every situation. Hi, Zara, welcome. Because that is what will actually adjust the number that you have to fall under. So yeah, we're definitely going to talk about that. And I think in the slides, there's going to be a chart that shows how the number increases by household size. Because yeah, it means nothing unless you know who it's being used to care for, basically. Oh, here it is. I was right. Yeah, so it increases the number on the right, the poverty guidelines increases with the number of people in the household. So one of the first questions that we're asking in the beginning of that patient encounter when we're trying to gauge how to allocate resources and decide which direction to put them in, it's based off of household size. I will now pass to Megan because I forgot this was hers.
Yeah, so if any of you guys are aware, in December, Medicaid expanded. So now for all people, the federal poverty line, not the federal poverty line, but like the amount to which you can qualify has been increased to 138% FPL. So that's why that 20,000 number was really important, because that's the cutoff for Medicaid for one person. And so this is just a chart on the right that shows you the 100% poverty line. So you can kind of calculate. So we were talking about between 100% and 400%, they may qualify for premium tax credits. So that's how you can kind of calculate based off of the 100%, whatever that number would be. So as a practice, what would be 200% FPL for a family of 4 based off this chart? If the chart on the right's 100%. You don't have to like give me the exact number, but yeah. Yeah, exactly. So that's how it is. Any questions on FPL? Cool. So as we were talking about earlier, the summary of benefits and coverage is a really important document that every insurance plan will have. And this uses plain language to explain to consumers their healthcare insurance plan. The point of this is that people should be able to understand their insurance plan, even if they don't have a lot of information about, like the information that we have about health insurance. It's really important that we review the summary of benefits for each plan to find one that works for the needs of the consumer. So this is a document you'll get really familiar with, especially as you're going through the marketplace. And the company is expected to send a copy of this within 7 days of a request from their client, but it's also something that we can see online whenever we're looking at insurance options. So this is where, as we were talking about earlier, you would see kind of how the plan works. If it's, if they're covering, if you can have co-payments before the deductible, or if they expect you to pay all the way up to deductible before they start coverage. I'm trying to see if this one on the right even shows any of that. It doesn't, but that's where you would find it. Any questions on this? Cool. This is also where you'd find like the cost of like if they had to go to an emergency room or like any kind of service. This document's usually like over 10 pages long. So if you have a client or a consumer that says they have like a very specific need, like they need to go see a neurologist, for example, or they need to see a psychiatrist, you'd be able to find exactly what that service is and then the cost of that care based off of this. So it's really important to get familiar with this. Okay, so now for some vocab practice. Question 1 is Sarah is visiting her primary care doctor for an appointment, but she is getting referred out to another provider for some individualized care. After her visit, she gets a bill with the full amount for the services. This is likely because the new provider is blank. Anyone want to volunteer? Yeah. Hello. Oh. Okay. Do you have an extra one? Okay. All right. Does anyone want to volunteer to try and answer? Yeah. Yeah, exactly. this provider is not providers of insurance company, so
Mhm.
if they were in it, that would like help manage costs and lower the amount she has to pay, but if they're out of network, she has to pay.
Yep, awesome.
Let's just go ahead and do the other multiple choice question.
If I keep clicking, will it happen up here?
Oh, that one.
No, it's not valid, but you have it, Megan, on your.
Should I just ask it?
Yeah.
Okay, sorry guys. Okay, so now for the next question. Kiara is a volunteer who is working with a client to decide what plan may be the best option for them. She gathers from her conversation with her client that the cost of the premium is a priority for her client. What pieces of information will not directly help Kiara in supporting the client? You can take some time to think about it. Would anyone like to try this question out? Yeah. Yeah. Can you tell me more why that wouldn't help?
Summary benefits of coverage, and I do about what the but no matter what provider she goes to, like states.
And why would the estimate amount of PTCs help? Mhm. Awesome. Do you have anything to add? Yeah, so they were talking about how to determine the cost of the premium, first of all, it's always really important that we consider the needs of our consumers. So that's why what the client's ideal premium amount is really important for us to know and something that's important for us to ask our consumers. And then they're also talking about how what providers are in network versus out of network isn't really helpful for the purpose of understanding the monthly premium, because regardless of which provider you see, that doesn't actually change your premium amount. It just it changes what your out-of-pocket amount is. So that's why that would not be important. And then the other ones are directly related to premium. So the amount of PTCs that would, reduce the premium for each month, and then summary of benefits and coverage would show you it would have on there like the monthly premium as well. Anything else? Okay. And then definition. Okay. Sorry guys, we're going. Huh?
You can do their reflection. Both of them. There's one on the front.
Oh. Okay. Sorry guys.
Well, so they can-
Okay. If you guys just want to if you look at now you guys have this worksheet, if you can take 10 minutes to answer reflection 1, what qualities do you want to emulate as a volunteer or CAC for Get Covered Carolina at SHAC, as well as now that we've gone through some of these examples for these terms, just write a definition in your own words on the next sheet for network, premium, deductible, copayment, coinsurance, and premium tax credit. And we'll walk around to answer any questions that you guys might have.
And then I wanted to just say, like, in your own words is a really big point. So I would ideally, you should probably write it on the sheet how you plan to explain that term to a patient. Because I think that's helpful to refer back to is like, what's the simple way that I would be able to explain this to a patient? And then like add notes for yourself about what we talked about.
And you can work together. We're gonna walk around and answer any questions if you don't have. I don't want to meet. Hi, I'm doing. Yes. So what question? Yeah, yeah, I'm really lucky. So I'm feeling pretty good about what I covered so far. You were very lucky. Yeah. Yeah, that's a good way to explain it. We're gonna talk to practice how you make students. Okay. So we'll get that all to it. Yeah, they're all. Lily. The 6 terms, you can look at the comics, those are something helpful. You can do the reflection, please do reflection. And raise point, if you have a question.
We're not doing this. This is like, yeah, okay, so do you want to finish these?
Yeah.
We could pick it over. Right here.
Okay, I'll send the sheet. Okay.
I really threw that on you. I'm gonna read these slides really quick.
Okay.
Whatever I text you, I text you. Oh, okay, that's. And then go. I've been this. I mean, I don't think so. I said providers and services that, I will. And then periodic is too big. I mean, he's not good. Or we could just move it. They have that one. No, I grew up in downtown, like, yeah. Well, this is fine, so like, I think. It's like, oh my God. And it'll say, alright. Where do you think they're like? So they have stated their own exactly. But I also would mainly like. We'll get to Medicaid for that $100. Yeah. Wonder you heard of. I'm so sorry. Oh my gosh.
All right, let's come back together. First off, hi everyone. My name is Zara. I'm the other co-director that works with Get Covered Carolina, and we're so happy you all are here. It's really exciting to see so many people excited to train with Get Covered Carolina and get going in our clinic. So thank you for being here today on your Saturday. Any questions before I keep going right now? No? Okay. At some point, Verena, just tell me when it's most applicable, but at some point, I think we should talk through the math problem of like, okay. I honestly can't remember exactly what the math problem looks like, but just, can you tell me what I have to do and then I'll do it? Okay. Yeah. Okay. So we went over, we just made a practice scenario, right? Okay. Let's do that. I'm going to write over there. Can everyone see if I'm over there?
All right, so bear with me, it's been a while since I pulled this question back up. But we are gonna just make up a scenario of some random person with some random circumstances, and see what their healthcare costs would be, okay? So, let's start out with a patient that we're working with, and, they are getting a plan, and their premium is gonna be what? Anyone give us a number? What do you want their premium to be? $100. So what does that mean? What does $100 mean? Every single month, they're gonna pay this premium, right? Okay, so when they first sign up for their health insurance, when did they actually start paying this? The day that they start their health insurance? Yeah. When is it? Yeah. Not if they need a deductible, no. They will pay this no matter the deductible. Yeah. Start date of the next one? Start date of the next one, yes. And it actually depends where they're kind of signing up for their plan. Start date of the next month is a general good rule, but if you're signing up in November, your plan is gonna start in January. If you sign up in December before the 15th, your plan still starts in January, on January 1st. If you sign up after December 15th, your plan starts February 1st, yeah. So on the first of the month is when they're gonna get charged $100. That's their premium, per month. All right, so what do we want their deduct? 1,000, okay. And what does that mean? And tell me your names, by the way, while you're talking, just so I can kind of get.
I'm Grace.
Grace, okay.
And their deductible means that that's the amount they have to pay before they start like.
Kind of, yeah, that's pretty general, definition. What is it that insurance will cover before they? Preventative, yeah, primary care. Yeah, they'll still have their copay applied, right? So that number won't change, they won't be paying out of pocket, they'll pay the copay amount, per appointments. Anything else? Okay, what happens after their deductible? After they pay $1,000. Now what is insurance doing? Yeah, so now insurance is covering some services. And what is, how do we know that they're covering a service? What is it that we look for in the summary coverage? And what's it gonna say? What's that word? Not copay, but coinsurance, right? We're looking for coinsurance. Anytime we see the word coinsurance, we know we don't even have to worry about that number until this client has met their deductible. That's what we're looking for. So we put it at $1,000. Let's say that going to the doctor for this person costs $50 for a primary care. And then let's say a specialist costs $150. Okay. So this client that we're working with has a special condition, and it is called, I'm tired of winteritis. Okay. And they are just suffering, they're ready for spring. And, so they come into the doctor's office, the doctor, their specialist says, yeah, this is what you have, this is your condition. And they go ahead and charge them that $150. Okay. And they did this when they first started their payment. They started on January 1st. Okay, they went to the doctor, let's say, January 15th, and they went to the specialist, so they got charged $150. Okay. Now after they went to the specialist said, well, now you need to go to the winterologist because they need to make sure that everything's well, they need to do some labs for you. So let's go ahead and make you an appointment for April, right? And this guy charges $150 as well. And their team also collects some labs, and let's say those labs are $100, okay? And then after this, after April, this patient has a big fall, right? And now they're in the emergency room. Let's say they have $1,000 bill. All right, so in your teams, I want you to take these numbers and the premium and figure out when their deductible is. Everyone understand the task? How to work on this.
So like.
So what she was saying is that, you know, how your deductible is the minimum amount you have to pay out of pocket before your insurance does anything. She was saying a lot of times when you use a percentage of your income of that isn't the case where your insurance will cover it beforehand. But this was kind of the case in my case that I had talked about, because it is a little bit more nuanced where it didn't plan. But like she said, yeah, it was just here and stuff like that. Things will, I'll make it for them when it comes to reduce costs based on like copay, co-insurance, some of that will still apply to certain years. But it doesn't.
But like, I don't know, like, you're
Like until it's.
Oh, got it.
Okay. Additional piece of information. The insurance bill, or the emergency room bill.
which is $1,000. Usually emergency room is covered under co-insurance. So let's say when you're looking at the summary of benefits and coverage, this emergency room bill says it's a 50% co-insurance.
After deductibles, but
After deductible, yeah. Because co-insurance means after deductible. 50% co-insurance. Okay.
So yes, what she was saying is. Yes. Not as awesome. Yes, she is telling you.
Yeah.
Yeah, what she's asking is how much, because she's not. Based on what's being. So really what that's one thing that's really or the.
Let's just assume we do that. All right, let's talk about it, y'all. Okay, so. Let's go slowly. Let's first add in, is there anything else on this timeline for this client that we have not added into their costs? Anything else they're gonna pay? Premiums, okay, so when are they paying their premiums? Okay, the premium right here. Yeah, one right here. March 1st. Okay, so they paid how much in premiums up until June? $600. Is that what you said? Yeah. Okay, so that's another cost that we have that we hadn't added on to this. But what's special about the premium? Does it get added into your deductible cost? No. So we don't really care about this cost, it's in red because we don't really care about it in relation to if we met the deductible. Okay. Now, the co-payment, yes, that does add into the deductibles. Here's co-payment that adds into the deductible. Here's a lab that, let's say, there's no co-insurance on this, it's just a co-payment of $100. Also adds to the deductible, okay? Yeah.
Wait, the PCP isn't all the time with the primary care provider?
Yeah, let's say they skip the PCP, they just went straight to a specialist, just right. Okay, so what are we at right now in April for their costs outside of their? We're at 400, okay. Have they reached their deductible yet? No, okay, so is insurance paying anything outside of their co-pays, that co-pay amount? No, not. Okay. Then we have this emergency room visit that we said is $1,000, and I gave you this additional piece of information that the co-insurance on the emergency room visit is 50%. Does this apply right now where we are? No, it does not. But what you can do is, because this bill will put us over our deductible, right? We'll be at 14 once we finish paying this emergency room visit. We can actually split the payment of the emergency room into what will meet us to the deductible, and then whatever's left, we actually apply the co-insurance. Okay, so what do we need to add to this bill from this emergency room visit that will reach us to our $1,000 deductible? 600, okay, so 600 of this is gonna go straight out of the person's pocket, right? Insurance is doing nothing with that. But insurance says, okay, great job. You have paid $1,000 to me on top of your premium. So now I'm gonna start helping you a little bit more. And the rest of your $400 on this bill, I will help you with. So how much is insurance gonna pay and how much is the client? 200 for each. So 200 for the client. And 200 for insurance. In total, how much has the client spent on their health? 1,000. Yeah, does everyone agree? Everyone know we got that number? We added this one, which was out of pocket, no co-insurance.
We added this one, out of pocket, no co-insurance. We added this one with private co-insurance applied to 50%, and then we added your premium. Now, we go over this math just so you have a concept of what it looks like. You will never be doing this math by hand. It is very rusty for all of us, so that's okay if this was a little challenging. Like I said, never happens in clinic where you have to go through this math, but it's super important that you understand it so you can explain it to someone, right? And we will show you the marketplace, which actually will do all of this math for you.
Yeah. And then really quickly, since this seemed to be a slight point of confusion, I just wanted to return back to these definitions.
Yeah, thank
So
you.
you noticed that Zara was referring to those cost of services as co-payments. The term co-payments isn't necessarily limited to the amount like to when your insurance really applies to that service, because they were paying this 150, this 150, this 100 before their insurance kicked in. We're still referring to that as a co-payment because it's the cost of the medical service. So it's a very general term. Because I know you guys were like confusing that with like when the co-insurance starts to apply. Does that make sense? Do you guys have any questions about that? Okay, what's your question?
This is about the premium. If the premium starts a month after insurance, shouldn't it be 500 February, March, April, May, and June?
It doesn't always start a month after. We said that this person's plan starts on January 1st. So in theory, let's say they signed up on December 2nd for the plan, right? And then it'll start, yeah. Yeah, but good question.
So even though they haven't paid the $1,000, the co-payments are still the value set by the insurance company for those services.
Yes.
They're still like receiving some benefit.
Exactly. So that's why we said the benefits they receive before they meet their deductible is the co-payment set amount that the insurance has decided on. And then afterwards, insurance says, well, there are these additional services that we can help you cover as well. And you'll look at the summary of coverages and benefits and you'll see how they kind of divide them up. Primary care specialist always has a co-payment, whereas things like emergency room, inpatient surgery, just like bigger things will have a co-insurance usually attached to it. Yeah. Okay, should we keep going? Alrighty. Good work, everyone. Let's keep moving. Okay, so we are going to shift into talking a little bit about the options that are available to consumers in the United States, and we'll talk a little bit about the ACA as well. So here's a broad overview of some of the programs that we work with and that you will support consumers with. So first off, starting with the marketplace on the far left, this is a type of, the marketplace actually is an environment where we have private coverage plans that are available to consumers during open enrollment, right? And this period of time of open enrollment is from November until January. It used to be November 1st until December 15th. And then with COVID, I think over the last 2 or 3 years, they expanded it to January 15th, and then they kind of just stuck with that. So the period is about 2.5 months long. This is a time that we are very involved, obviously, in the community and helping with enrollment. And just a little tidbit about Get Covered Carolina, we used to only operate during this period of time, and now we are a full year-long clinic that does services outside of open enrollment. So we have the open enrollment period, but then we also have special enrollment periods, which I think someone will talk about, or maybe I'm talking about that. So special enrollment periods we'll get to, but these are periods of time outside of November to January that the government basically decides these are conditions that a person goes through where they might need a change in healthcare coverage. And so we're going to open a special time for them for 60 days after their qualifying event to give them an option to sign up for insurance. Okay, so those are really the 2 periods of time where we do marketplace enrollments. And this is an ideal service for individuals between healthcare coverage of 100% FPL and 400% FPL, which actually I wanted to go back to this question, this page really quickly and make sure that everyone knows how to read this. I know when I first learned about FPL, and when I first learned about FPL, I was like, what are you talking about? What does it mean to be 100% or 200% or 138%? So let's just look at this for just 2 seconds because it actually does apply to a lot of the things we do. So on the left, often you'll see a number equating to how many people are in a household. And on the right, you'll see either annual or monthly income that that person has to be under, right? So a limit of their income, okay? So you can see on this chart, we say that if you're in a 1-person household, $15,000 is what we consider the FPL, the federal poverty line. So it's literally a line that we draw. And we say anyone that falls above this is not considered in poverty. Anyone below this is considered in poverty. And I'll give you some information on that. It's actually a really outdated system that we have to measure who falls under poverty. It goes back to, I think, the either the 40s or the 60s. I can't remember exactly when it was. But this lady decided that to fall under poverty, we need to make sure that you are making no more than a third of your income work towards food, right? So that's how they measure poverty, even to this day, right? They determine how much money you need to live, to eat food, and they say, okay, let's multiply that by 3. And that's going to be the federal poverty line. And it's really outdated. It's really awful. We have an absolute poverty system in the country. So that's where we fall, right? Nothing we can change about that, but just so you understand where that number comes from. And so then if we say that we are looking for 138% of the FPL, what do I do? How do I use this table? What do I need to do? Any ideas? Yeah. Name? Carson.
1%. Also go over, that shows 100%. Multiply by 1.
Yes, multiplied by 1.38, which falls around 20,000. What about if we had we want to know what was the 200% FPL for a family of 4? Yeah. Name?
My name is Maida.
Maida, yeah.
I'm the 4-person
Mhm.
household, which is 31,200.
By 2, so about 62,000, right? Okay. Never do you have to memorize these numbers, but some numbers are going to be a good idea to know, and we'll give you some of those ballparks, like 20,000 is going to come up, 15,000 is a good one to know. And you'll just get familiar with them as you keep using these numbers.
Also change. So for
Every year.
It's really, really important to make sure you're always looking at this updated information for that year. So definitely keep that in mind. Make sure that you're looking at 2024 poverty guidelines for everything.
Yeah, and I am a big Googler. You will learn this about me. I'm all about us becoming expert Googlers as well. Yes. So when I Google the poverty line and I look for a chart, I always want to make sure that it says the correct year, right? So 2024. And a lot of times on images, you'll see 2023. So just be aware of those numbers. Okay, excellent. So that's how we read these charts. And then let's go back to what we were saying here. We said this was an ideal plan. The marketplace is an ideal space to start looking for insurance if you fall between 100% and 400% FPL. So are we clear now of what that means? Okay, wonderful. Why is this ideal for this group of people? Yeah.
They're not like technically in poverty, but they still.
They still can't afford an extensive plan, but they're not technically in poverty. And why does that make it that this is a good option? What is it? What's special about the marketplace?
What also has the requirement of being between 100 and 400% FPL?
Yeah, premium tax credits. So premium tax credits is why we say the marketplace is ideal, right? For people who fall between this limit, because between 100% and 400%, you will be eligible for premium tax credits. And I think whoever was talking about that probably told you all that it's kind of an inverse relationship, right? So whenever you make less money, your premium tax credits are going to be more because they say you need more discounts. We need to help you a little bit more. Whereas if you make more money, your discounts are a little bit less, okay? And actually someone asked me, do you not have discounts after 400%? You do. There are still discounts. I think that's a kind of a recent change, but if you are, I think in the past year or two, Megan, correct me if I'm wrong here. Is it year or two that it happened? It's not like something super recent, but they're covering past 400% FPL for premium tax credits. Yeah. Okay. Good. Marketplace. We will talk so much about marketplace. So, okay. Medicaid is the second plan we have here in the middle, and this is a coverage plan for low-income individuals and families. Again, the federal government said, well, we need to have a healthcare option that is available to people who fall in the low-income category, right? That was kind of what it was designed for. And then before any states ever expanded their Medicaid, they said, well, we don't want to just cover people who are low income. We feel like there are special categories that that kind of deem you as eligible for support from the government for your health coverage, okay? So in the past, those categories were that you are a child under the age of 19, you are a parent or caregiver of a child under the age of 19, you are between the ages of 65 and up, you are pregnant or were pregnant within the last, I think they used to have it as last 2 months, maybe something smaller than a year. And then you have blindness or a disability. And when we say disability, this is a disability that's been recognized by a physician, and you have a formal SSDI. Now, expanded Medicaid is a little bit different. And finally, our state has decided to invest in this. And we've basically taken out these categories because, as you can imagine, the big category that gets left out is this ages 19 to 64, right? So people within the ages of 19 to 64 who were not caregivers, who did not have a disability, who were not pregnant, but were extremely low income, had no options for health coverage because they did not fall within 100% to 400%, so they weren't getting premium tax credits, right? They were probably 100% FPL and below. But the government deemed that they didn't need support, okay? Do you have a question? Tanvi, you have a question? Yeah.
So again, this is all new, so one thing to add here is you have qualified for both marketplace and Medicaid. So in states that haven't expanded, it's 100% to 400% for premium tax credits, but now in North Carolina, that limit has been expanded, so it's up to 138% and lower for adults ages 19 to 64 to qualify for Medicaid. So if you see a consumer that's, for example, at 138% federal poverty line, they actually would not qualify for the marketplace, they would qualify for Medicaid. So just something to keep in mind that they can't qualify for both. I know there's a little bit of overlap right now, that doesn't apply to North Carolina, which is good. Medicaid's very, very comprehensive.
Yeah. We will repeat that statement over and over again. We will do some practice with it, because we're trying to build you up. We're trying to build your levels of knowledge here. But yeah, thank you for that important piece of information. Okay. So that's what Medicaid looks like. And we do a lot of Medicaid applications. We do a decent amount of marketplace usage, not necessarily applications, but we definitely use marketplace and we're very familiar with it. Medicare, on the other hand, is something that you all can have a superficial level of knowledge on, and that's okay. We're okay with that. But generally, Medicare is the closest thing that we have to universal coverage, and it covers the group of people who are 65 and older who have been contributing taxes for 10 years or more. So this is super important. We literally just had a situation in the clinic where a medical student who was working on the team said, well, they were talking to their client who was 68, I believe, and said, oh yeah, you definitely qualify for Medicare. Like, let's get you going. Let's get you set up. And this client got all excited, right? Because this medical student's thinking 65 and up, I know that's Medicare. Like, I got this. Turns out we had to bring our team in, and Megan was the one who was the coordinator that night and had to explain that, unfortunately, because you've not been contributing taxes for the last 10 years. And I think this consumer had just maybe just moved or.
They've been a resident, qualified present resident for 4 years.
4 years.
We'll get to, but that.
Yeah. Yeah. So they were under their limit, right? And unfortunately they didn't qualify for Medicare. So it's a little bit more complicated than just the age, but definitely like a group that we start with. Yeah.
Not paying for that, like, how would they know if you don't have to pay taxes? You're not making like income.
File taxes, I think, right?
Well, they wouldn't qualify for Medicare, but if they have to have a
Okay.
spouse that is working, that's just how Medicare works. You have to be paying for it specifically the Medicare tax. So like if you guys have a job, you really don't have to have a certain amount out of your paycheck for Medicare. So even if they file taxes, if they're not making any money enough to that, and their spouse would be there for 10 years, they're not qualified.
Now, do you have to, is it between the ages of 55 and 65, or is it any 10 years in your life that you can do
This
this?
first one, they only make it for 4 years. We'll get to like what that means in a little bit for what else they might have been qualified for. But no, they hadn't contributed with any point.
And again, it's so complicated. I mean, there are these parts to it. I know there's a lot of HPM people in here. You probably know about parts A, B, C, and D, which you'll touch on in the modules, and we will touch on a little bit superficially in the lectures. But really, when it comes to Medicare, we recommend you usually work with your coordinator and send them to the healthcare department. It's not our specialty. It's something that's really delicate. There's a time-sensitive window, so we don't want to kind of disrupt that. But it's really important that you have the information to get people to those resources. Okay. Alrighty, broad overview. I mean, we are going to go into so much more detail, so let me just keep going here. Starting out with the Affordable Care Act. Does anyone know what the Affordable Care Act is? I think probably some of my folks who've started the modules know. Anyone want to give it a shot? Just give us a little snippet. When was it created? When was it put into act? Yeah.
Obamacare, and I think it was like 2010-ish.
Mm-hmm.
And it made the federal marketplace where you could buy and shop for plans.
Yes.
If you're between the income eligibility.
Yeah.
And those are the kind of subsidized plans. I think.
Exactly. Name? Neil. Okay, great. Perfect. So started in 2010 by Obama's administration, also called Obamacare unofficially. But we will kind of call it ACA just to make sure that we're calling it the formal name of the title. And you'll see that all the time, ACA. So the ACA was created for a lot of different reasons. The main one to make healthcare consumption easier for consumers, more equitable. It did a lot of things that really helped the healthcare coverage sphere, including taking away what do we call it? Like the pre-existing conditions that restricted you from having health insurance. It offered a really easy tool for you to shop for your healthcare coverage options, which Neil mentioned is the marketplace. And we'll talk about window shopping. It made sure that all health coverage plans that are on the marketplace follow a certain rule, which is that they have these essential health benefits, right? So every plan that is vetted by the marketplace kind of follows these criteria and offers the same type of coverage for each person, okay? So lots of really, really great benefits with the ACA. But I think when you talk to consumers, oftentimes you'll not hear them refer to it as ACA. You'll hear them asking you, well, I know about Obamacare, or I think I'm eligible for Obamacare, and I paid $10 a month, or something along those lines. And it's important to understand what they're actually referring to. They're probably not referring to the entire ACA. Yeah. But oftentimes we'll explain what the ACA actually means and why it actually supports their coverage. We talked about easy to compare and streamline approaches for accessing all qualified health plans, which is why I talked about that requirement, that basic requirement that all health plans have to have. And what's really great about healthcare.gov, the marketplace, is that you can also enroll in Medicaid. So Megan talked about, I was going to say Medicaid. Megan talked about how you cannot have Medicaid and the marketplace coverage at the same time, right? So how do we prevent people from having both, or trying to apply to one when they're actually eligible for the other? And the way that the federal government came up with is they have put a screener into healthcare.gov. So either you're going to pop up that you are eligible for PTCs on the marketplace, or it's going to pop up that you are eligible for Medicaid. So it's actually really easy. We really can't mess that part up. Obviously, there's still some nuances and still some things we don't want to, it's always an estimate. We don't want to ever kind of commit to something that we are using the window shopping tool for, but it's really helpful to kind of eliminate that confusion. Okay, video. Here.
Yeah, raise your hand if you've had for health. They're like, yeah, during open enrollment, they're really everywhere, and that's because it's such a limited time range. So since it's only that November to January, they really, really push sign up, sign up, sign up. So I see like a million ads for it all the time.
And now you will also push sign up.
Yeah.
Okay. So we talked about this in the video. Insurance plans now must, actually, we didn't talk about this in the video. So some other things that the insurance plans must do is provide a summary of benefits and coverage, and they do so in a really standardized template. So we will look at those. They're also required to mail a copy to consumers if they've requested one. So this is something that you should definitely let your consumers know. Oftentimes when we see patients who already have health insurance, their biggest concern is, I don't really know how to use my health insurance. And so that's where we can step in, because we can be like, oh, no problem. Let's go ahead and pull up your summary of benefits and coverage. We can print you off a copy in the clinic. You can also, let's call this this number, and we can actually request them to send you one to your home. Then you can also work with them to figure out which services they're going to need to use, and then maybe even find them a provider on their health insurance website. Providing coverage for consumers with existing conditions. We talked about this, covering that essential set of what's called essential health benefits. And these essential health benefits, there's 10 of them, and that makes them a minimum health coverage. I think that's called minimum health coverage when you meet these essential health benefits. There's so many acronyms here. So MHC is including these 10 essential health benefits, which then makes you a qualified health plan if you're on the marketplace. Okay. And then they retract any annual or lifetime dollar limits. So really consumer centered. Alrighty, so let's see. Other things here is that children can stay on their health insurance plan for their parents until they're 26. Prohibits discrimination against pre-existing conditions. This one was big. I remember before 2010, I remember asking my parents about this actually, that it doesn't make sense that someone with like, you know, heart disease is discriminated against and has higher insurance. And my parents were like, well, that's the way it is. And then it got changed. Yeah.
Still going, so if you are like hospitalized or doctors.
What's the one circumstance that we can like still take into account? Well, insurance plans can take into account with your premium. It's smoking. So smoking, they can still take into account. And you will see that when you're doing the screener, that that one of the things that your client has to answer is, are you a smoker in the last 6 months? Okay, and then you might also see during enrollment, open enrollment time, there's a lot of smoking cessation advertisements as well, because if you commit to smoking cessation, then your premium goes back down and all these things. But if you are hospitalized a lot or you're using your insurance a lot, I mean, really the only thing there is you need to find a plan that works for you. And we'll show you how to look at the plans and see based on how much the consumer thinks they'll use their plan, which one is the best option for them. So if you think you're not going to go to the hospital that often, like maybe ever this year, and you're pretty healthy, then maybe you get a certain plan that kind of meets those needs. Versus if you know, I have a lot of conditions, I'm going to be using the hospital. Verena and I were working with someone who knew they needed a knee surgery. Was it knee or hip? Hip, yeah. Some type of elective surgery, right? Something that really was essential to their quality of life. And they knew that that was going to be something that they wanted to consider when they were picking their plan.
And then the thing we're gonna talk about is like, is the main two numbers that we've been discussing again and again is the premium and the deductible. And they do have a relationship where like increasing one, sometimes there's a relationship where it's like, we'll explain it more later because I don't want to confuse you guys right now, but you can kind of see, do I want to be paying more per month to have like a lower deductible, or do I want to have a lower cost per month because I know that I don't like really get, you know, have to go to the hospital that often. So there's ways to look at that and see how to kind of titrate it, for lack of better word. Yeah.
That's good. And then here, this last one prevents companies from canceling coverage unless the premium isn't paid. So that was super important, right? Plans could just, I was too young, but I don't know exactly what the reasoning were, but plans were just canceling. Maybe because people were using them too much. I'm not exactly sure, but now they cannot do that. They cannot discriminate in that way unless the premium is not paid, that monthly contribution. No charge for preventative services, makes prescriptions more affordable, coverage more affordable, and then expanded employer-based healthcare. We'll talk a little bit about employee-based healthcare, but I'll skip over that for now. Okay, some vocab here is open enrollment period versus special enrollment period, and I already touched on this. Instead of going over what's on the left, I'm going to show you all what's on the right here. So some special enrollment period qualifying life events that we have here is if you've lost your coverage, right? So for some reason, generally, you've lost your healthcare coverage. That qualifies you to be to get onto the marketplace. If you've lost COBRA benefits, does anyone know what COBRA is? COBRA is the temporary insurance that tides people over between jobs when they've lost health insurance from an employer. You can apply to COBRA. And usually I think your like benefits plan when, or your package when you leave includes talking about COBRA. If you've gotten married recently or divorced, that's a qualifying life event because something has probably changed in your family structure. If there was a birth in the family or an adoption, permanent relocation. So this is usually moving to a different state. I think in some situations it can be moving within states. I actually got really confused lately about that because we had someone who moved between the state and we were trying to figure out if they had a special enrollment period. Spoiler alert, I did not find out the answer, but I think generally it's between states that this comes into play. If the previous policyholder died, adoption, name, a different legal guardian, what does it say? A foster child, change in citizenship, and then newly eligible for government assistance. Okay.
And definitely like, don't like disregard the possibility of a special enrollment period.
Oh, no.
Like you really need to consider that someone might possibly fall under this category.
Yeah.
I had been in situations where it's like, oh, we just had a kid. I'm like, oh, okay. So you have to be aware of this just because we said, November to January, that's not the only time you should have in the back of your head.
Yeah.
Marketplace. So yeah, just keep that in mind.
Which is great because now we're a full-time clinic. So we, can help people in these periods of time. But to Verina's point, we hear it oftentimes where people will be collecting a history of their patient and maybe they're reporting back to us or like kind of discussing some options as a group. And they'll mention one of these qualifying life events and we'll say, did you talk to them about healthcare.gov and if they're eligible for a special enrollment period? So it gets missed and we want to just kind of really drill it into you all to think about these special enrollment periods. This is another video that just goes over what this. Sorry, I think I will skip it. Okay. Is this the question we want me to do?
Yeah.
Okay. So I think this is on the, I'm so sorry. I messed up the printing a little bit, but I think this is like somewhere before the 4th page or something.
Yeah, you switched up the order a little bit, so it might not be in the exact order that it's up here.
But a patient asks you the following question while you are discussing options for them in clinic. So the question is, why should I get health insurance or health coverage? That is the question. How would you respond to this?
Yeah, so under group activities, question 1, this is like the same question reworded. Did you discuss like the form of penalty? Because this one is saying, why should we get health insurance if there's no penalty for NC consumers?
Okay, we'll just talk about this question then. Does anyone know what we're referring to when we say penalty? Maybe people have started the modules a little bit. Yeah, Neil? Yeah, if you didn't have health insurance. So part of the ACA was also to create an incentive, a negative incentive, of course, but to create incentive, they put a penalty on anyone who did not have healthcare coverage. Okay, so you needed every single person needed to have a qualified or needed to have essential health benefits in some form, whether that's employer sponsored, whether that was Medicaid, whether that was something from the marketplace, needed to have those essential benefits or they would be charged, right? The Trump administration, they didn't take away that kind of clause in the act, but instead they changed the penalty to a $0 penalty. So then starting in 2016, there was really no incentive for people to have health insurance, right? Obviously, I think a lot of us are public health minded and we know from a public health perspective that it's super important to have health insurance, right? And we want people to be excited to have health insurance on their own, but the government had put this clause in place to just kind of give you an extra push to have your benefits. And then that got taken away in 2016. So really from 2016 to 2020, there was a lot of discussion on how do we encourage people to get health coverage, because this question get asked a lot, like why do I need it, right? Does anyone have any ideas about like what you would tell a consumer if they would ask you, why do I need health coverage? It's a pretty broad question, but,
There's could be like a lot of different answers.
oh yeah. What's one thing you'd say? What's one benefit? Yeah.
Help you reduce your costs for-
Yeah, help you reduce your overall cost for receiving healthcare. What else? Preventative care. Perfect, yep. Nate? Sunbeam, okay, wonderful. What else? What about if you have like something unexpected, an accident, need to go to the ER? Right? It can help you with those extremely unexpected bills or situations where you don't expect to need some type of support, but now you have a really big healthcare coverage bill, right? And that was a question that would come up a lot if people would say, well, I'm healthy, like well, I don't even go to the doctor anyway. So why do I need health coverage? Well, you know, things happen and we can't expect everything. So it's also good to have that safety net. I don't know if I mentioned this, but the ACA also created us, which is super cool because they decided that the Affordable Care Act decided that we needed a group of people who were volunteers and paid, who did this type of work in the community to help educate, to help support with enrollment. We were all kind of trained in the same way so that we could kind of spread this message the same manner. Okay. So I think that's pretty cool to know that the ACA contributed to this. Yeah.
So
I don't know because I think it's a wonderful thing. I think a lot of it is financial, thinking that thinking that offering discounts like tax credits or offering expanded Medicaid is going to hurt the dollar of the state, right? When in reality, there's a lot of studies that show that it actually is more financially beneficial to expand Medicaid and to provide premium tax credits to people because they're receiving preventative care. Yeah.
what about like the Constitution?
You might know more than I do. Tell me what you know.
Well, I just know that like a lot of like Republican Congress people
Mhm.
like say that like the ACA is like too expansive and that makes it like unconstitutional.
Yeah.
Because it's like not giving people like as many options or something like that. I don't know.
Yeah, which is kind of ironic because I think we feel like the ACA and the healthcare.gov has really opened people's options. I mean, like that rhetoric is always going to exist. There's always going to be that political dialogue. But I think knowing as CACs that the ACA has really created a way for it to be more equitable to get healthcare coverage. It's easier. There are people to support you. You cannot be discriminated against. Like these are really important, like basic things, right? So I think I feel like it's a good thing and you can form your own opinion about it, but thank you for bringing it up. Okay, let's go to the next question. Okay. So remember I said there's all these acronyms. Here they are. Qualified health plan, essential health benefits, and minimum essential coverage. So minimum essential coverage is this yellow box that includes these 10 blocks: lab services, emergency services, prescription drugs, so on and so forth. And each of these is an essential health benefit. Okay, 10 essential health benefits equals 1 minimum essential coverage. Okay, so those are these two terms. Now, what is a qualified health plan? A qualified health plan is a plan that meets these minimum essential coverages and is certified by the marketplace to be meeting these requirements. Okay, so every plan you find on the marketplace is going to be a qualified health plan. And actually, every single year they do an audit and they figure out which plans need to be on the marketplace and which plans need to be taken off. And I know there was a big thing with, I forgot which plan it was, but some plan got removed recently and it was a big deal and consumers got automatically moved to a different plan and weren't aware, and it was just a lot of mess. But the healthcare.gov does, the federal government does screen for this and kind of make sure that all plans that they're offering are meeting these essential benefits. Okay, and going back to these essential benefits, there are a lot of things like preventative care, things that we expect or things that we don't expect necessarily, so ambulatory services or hospitalization. We also have prescription drugs on here and lab services, mental health, substance use disorder, and then we also have maternity and newborn care. Okay, and the chart on the right over here shows you all, is this whatever coverage type on the left, is it considered a minimum essential coverage? Okay, so you can see the marketplace plans will be minimum essential coverage. Medicaid, it is a minimum essential coverage. Medicare, yes, minimum essential coverage. Refugee medical assistance, which we will not talk about a lot today, yes, minimum essential coverage. Everything else after that, no, not minimum essential coverage. And there was really no regulation around this until ACA. So this is really great. Now we can't kind of say, well, the employer can't say, I offer you workers' comp, so you can't, you can't ask me for health insurance, or I offer you employee-sponsored insurance that covers 30%, so what else do you want? They have to cover certain things now. Okay. Good things, good things. Alrighty. Yeah, so qualified health plan is marketplace approved. Yeah, Neil.
So is it like, let's say you have an employee health plan that doesn't meet the minimum essential coverage, does that mean you're still eligible to go on marketplace and try and get?
Yes. Yes. So if your employer offers a health insurance plan that is not a minimum essential coverage, yes, that is a time where you are given employee-sponsored insurance, but you can also go on the marketplace. Very important. Whereas if your employer does offer health insurance and it's covers 60% of your benefits, you're not eligible for the marketplace. Dorian. Yeah, actually, Dorian, introduce yourself really quickly and then. And Dorian is also a navigator. So you all have the CAC, like the certified application trainer, and then the navigator training. So he has both qualifications. So he's a really great resource for you all.
Very simple. Basically, the cutoff for determining when something's eligible for the marketplace is that if you're going to offer employer-sponsored insurance, that premium is around 8.4%, either for the individual or family, 8.4% of their income. If it's more than that, then you would consider them eligible for the marketplace because they're it's just not affordable coverage to them. So that's where you.
Good to know. Okay, so just to repeat that, if your employer does not offer insurance that is less than 8.4% of your income, then you can go on the marketplace.
So, I guess this is the point of looking at whether someone needs minimal essential coverage. I guess to determine whether to give that to the marketplace or not.
Like policy wise, it was more important when there was a penalty, number one, because you had to have minimum essential coverage to not get the penalty, right? Every person had to have that. Now it's more important for us to know what minimum essential coverage is so that we know if you don't have minimum essential coverage, you might not be covered for preventative care, for emergency room visits, for maternity care, for labs, for blood work, right? So I think for us, it's important so that, yeah, you know, if I need to go on the marketplace, if they might be eligible there, or if there's something else that we need to explore. Do you have something to say, Brenda?
Yeah. What's actually going to come up? What am I
Yeah.
going to know that this is true? It's because like you may be talking to someone and you're like, oh, do you have insurance? Like, how can we help you? And they're like, yeah, I have insurance. The next question that should always follow that is, are you satisfied with your coverage
Yeah.
right now? And that's when certain things like this could potentially come up, where it's like, no, actually, I don't have X service, and then you can talk about exploring options from there. So it definitely comes up in that way where you're like, okay, you have insurance, but are you satisfied?
Yeah. Or we'll ask, how's that working for you? Are you liking the plan right now? Are you able to use your plan well? Okay. Awesome. So I'm gonna spend very little time on this, but basically there's 4 different types of categories for healthcare coverage, and it just means how much the consumer will pay versus how much insurance will pay. And it's bronze, silver, gold, and platinum, going up in that order. So platinum insurance covers the most, bronze insurance covers the least. Okay, catastrophic health plans. This is a type of healthcare coverage that you will also see on the marketplace. And it is what it sounds like. It's really for when there is something that will go wrong that you cannot expect, right? A catastrophe, an emergency. It is very bare bones coverage. You don't pay a ton of money for it, but you don't get a lot out of it either. And the only people who are really eligible for catastrophic health plans are people under the age of 30, or over the age of 30 if you have a hardship exemption, because it is a cheaper plan. So there are some circumstances where you would be eligible for catastrophic. It is something that you should definitely be aware of because consumers will know about it and it'll pop up on the marketplace. It'll say catastrophic plan is one of the first options. If the patient is not eligible for much more, right? If that's like one of their cheapest options that they have, it'll usually pop up at the top. And again, it's a plan with a low premium, a high deductible, really for that worst case scenario situation. Yeah.
For like a young person who doesn't
Mhm.
think changes prevent it.
Yeah. 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 Exactly. And again, it was super important when there was a penalty to not having minimum essential coverage because you needed something, even though you know you're not going to use the doctor that often, there needed to be some option that people could sign up for when they fell in that category. They were young, they were healthy, they didn't have a lot of money to spend, or they didn't want to spend a lot of money, but they needed some kind of basic coverage.
And then really quickly, just because I alluded to this earlier, the whole like titrating the premium and deductible, can someone try and explain why it makes sense in this situation to have a low premium and a high deductible based on what you know about those two things? Like, why does that align with the healthcare needs that Zara just described? Yes, Carson.
If you don't think you're gonna go to the doctors like that often, you have a high deductible because then you're not expected to have to go have all these like co-pays and everything, and so it's gonna take more for them actually like the health insurance to kick in while you have low premiums because I don't think you're gonna need insurance that much, so you're only paying a reduced amount.
Good explanation. Does anyone have any questions about that?
Thanks, Rena. Again, something we will just breeze through because it's just not as relevant. I think Verena probably mentioned this at the beginning. A lot of what you learn in your modules is what you have to know as a CAC to kind of have that certificate. And we have a very specialized baseline of a base of knowledge that you need to know for our clinic. And I'll just try to remind you as we go through these that you don't have to stress too much about certain slides. This is one of them. So high deductible health plans is exactly, again, what Verena said. It's a low premium and a high deductible. It's kind of similar to catastrophic, but not exactly. It's not a catastrophic plan. But there are kind of certain plans that are considered HDHP. You'll see them as, can you give me some numbers? Like maybe you'll have $0 per premium because your premium tax credits cancels that all out, but your deductible is like $7,000.
They can be really high. Like the deductibles can get really high.
And then a health savings account. So with the health savings accounts are pools of money that you can use for healthcare services that are untaxed. And I need you to fact check me here. So health savings accounts can roll over, whereas FSAs do not roll over. You just Google it, yeah.
I think you're right, but I don't have to know.
Yeah, so this balance rolls over to the next year. So I think FSAs is the one that does not roll over. So some consumers will come to you and they'll be like, well, I want a plan that has an HSA because I really use HSA and I want to make sure that I am contributing to that. So you can use HSA for things like, I think you can use it in pharmacies to pick up like over-the-counter drugs or pick up your meds. You can use it to pay your co-pays, other things. I don't have an HSA, so I don't really know how to use it, but yeah, it's definitely something that comes up and you can work with your consumer if they're interested in having that on their plan and just looking for that in the options. Do you have anything to add, Doreen? No, okay. Yeah, it's not super common for us. Yeah, maybe like 1 or 3 times, yeah. Oopsie. Alrighty, and same thing here. This is something that we do not see as often, but every now and then, I literally just had a consumer who came in the other day. Actually, it was in December maybe. And they came in and they said, I want to make sure I have a plan that has a cost sharing reduction on it. I want a silver plan, and he already knew that. So cost sharing reduction is a discount that applies a lower amount to things like your deductible and your co-pays and your co-insurance. And it's only found on specific plans, which is the silver plans, which is why I put a little picture of the silver plan up here. Silver plans are 70% paid by insurance and 30% paid by the consumer. They're also called extra savings. So sometimes you'll see that word, that this plan has extra savings. That also just means cost sharing reduction. Yeah. So this is something that's really important. On the healthcare.gov website, when you start to peruse it and kind of put in some fake numbers to learn more about how it works, you might sometimes notice that a consumer's information pulls out that a silver plan is cheaper than a bronze plan because it usually organizes it by lowest premium to highest premium. You can change that to deductibles, I think, too. But usually be lowest premium to highest premium. And sometimes it'll pull up that a silver plan is the cheapest plan, and then it has a bronze plan, right? And so as a CAC, you might feel like, well, we already know that bronze is supposed to be cheaper for the consumer, even though, you know, health insurance covers less. So why is the silver plan coming up cheaper? It's usually because there is some type of CSR on that plan. Okay. So that means that it could be really relevant to the consumer, that could be a better option for them, and something to explain to them if you're looking at the options with them, that this plan actually has extra savings. Let's look at what that actually means for this plan. Okay, so I think we're ready now to jump into a practice question, and we actually might spend a good, probably till lunch, right? Is this, after this is lunch? Medicaid, okay. Yeah, because we're gonna one. Yeah, that's right. So let's spend like 15 minutes. I really want you all to just get acquainted with healthcare.gov. First off, this website down here, healthcare.gov/C-plans/. You're gonna get it ingrained in your brain like me, or it's gonna pop up on your suggesteds. And this is the place that you'll always start with. Healthcare.gov is also a fine place to start, just typing in that website. But this additional direction will take you to the window shopping tool. And that is something that you will use often with clients. And you will use it because we use the window shopping to determine if they're eligible for PTCs, if the client is eligible for Medicaid, because we said it does both for you. And then you can also use it to look at what their plans will actually look like based on their PTCs. So go to that website and please work with someone next to you. Do not work alone. I want you to talk to people and use the situation that you have here. We've tried to give you as much information. If there's something that you feel like you need, you can always ask anyone in the room if we can help you. But it's a pretty straightforward little questionnaire that you're going to answer. Okay. All right. So get familiar. This is like playtime right now. Okay.
What do you think?
I don't think we need to do 3. What's next after this?
They're also like ordered.
Oh,
Oh,
this
there's
is
only
2,
2.
yeah.
Okay.
I think we should be okay. And this one is just like, the second one is mostly about looking at, can we like stop this for a second? Because y'all have this scenario in your packet, right? You don't have it written down?
I don't think they have John.
I have Vinny.
Yeah. Yeah.
I'll leave that on the screen then. Okay.
Love this. This is so cute.
I love the little like comics that Josh and Grayson put out.
Yeah, this is lovely. I haven't been to training in so long, so this is good to see.
Sorry, you guys are over here.
Oh, you're right.
Yeah, she's still not. So that would just be.
Like, say like Jonathan living with his parents, what would they have this? It's like they're not.
It depends on how. But he doesn't, he's like, that's, if he is Yes.
Are they? Because the only two are, like,
Yeah.
but the,
Okay, so this one. I know what we were.
Do you actually want that? That's for children. And that has different.
if they don't like tell you, it's like outright, then that's the whole point of the screen is.
But now if
The
they,
children all have vision.
yeah, you can say that, but if you knew, that,
But that's,
if you knew that, John wasn't,
now that should be clear.
that's actually been really.
Wait, so- It like should super common now.
It is common now, it's just like less common for the children.
Right, that's.
Got it.
So that in parents.
Wait, you guys. Oh, no, that's another jury.
And then,
We,
like, if you're a child. If I
We
didn't
did
watch
start
that,
with
that's bad.
Yeah.
Yeah. You guys.
Yeah. I have a question. So, since his income is, does the, so you would put down that they, every single. Yes, every. Really young. We did like.
I can go long.
How much?
Yeah, because Amy's income is 0.
Yeah.
Yeah, said that they didn't have any.
Yeah, I do. We talked about this.
Yeah. If they were above 100. The first side. Since you're, since
We just.
yes, you don't need to pay any tax for the.
So they do have.
They have a key carrying.
Yeah. that's-
Yeah.
And like that.
Yes. Oh, of course. Wait, thank you. Good check. Oh, yeah, you're right.
But maybe below 230.
Oh, really?
Oh, actually.
Yeah.
Yes, so they're on.
I think I'll give you. Oh, cause you want, I was like, why is she sending me?
Ron, I know, Amy, and this lower than. So Ron. Yeah, that's all. I don't know.
Oh, so,
Yeah, so I was looking at like.
that's like this.
I don't wanna do like. It's much more cost. I didn't see
Yes. Yeah, okay. Like, I hope everyone knows generally.
We put this PowerPoint together last fall. Maybe something has changed, but is no one getting PTCs?
It might be because of.
No, it's, oh, well, it might be because it's for, is it saying they're eligible for Medicaid? Because of expanded Medicaid. Let's clap for expanded Medicaid. Ah, guys, we were so stressed out about that and we're so happy it's expanding. Yeah,
Summer first was a really big day, really big day.
yeah.
That's what we think.
It was a great time. Okay, so discard this. Instead of having them with premium tax credits, they are actually eligible for Medicaid. And I see a lot of people just went ahead and looked at what those plans look like and scrolled through. So that is great. There is another question, I think, some point about Alfreda. Do we want to go over this right now?
I think we might have time later, but do you guys
Yeah.
have like questions about the platform itself, like the
Yeah.
different features on it and stuff like that? 'Cause we can talk about that briefly and then revisit maybe another practice.
Yeah.
after we cover the stuff.
Yeah, let me just pull it up really quick. We were kind of popping up we were seeing some things that were helpful.
What have you guys noticed about dental coverage? Did anyone notice something about that? It's pretty rarely included on a lot of these. Dental coverage is not part of the minimum essential coverage. So I think that's an important thing to note, especially because we also operate outside of that's like where we provide some of our services. And so dental concerns are relevant for some people. And you notice like through a lot of those plans, you wouldn't be able to really meet those needs. So we're gonna talk about other types of resources later with that, but sometimes people tend to like loop in the dental stuff with the medical care. Those are like two separate aspects of health coverage.
Separate
And they
entities.
don't always align.
And, yeah,
I was
please.
gonna say, that's another really amazing thing that Medicaid expanded, that does cover dental. So that really helps them cover the gap.
Yeah. Mm-hmm.
Oh, right,
Yeah.
yeah.
Dental plans are also very different from medical plans in terms of they don't really have premium tax credits and also they have out-of-pocket maximum.
Mhm.
Not a maximum. There's a certain amount that dental plans spend on you every year.
And it's not a lot. It's like $2,000.
Same with like eye care usually. It's
Yeah.
similar.
So the important things to know about dental plans is that premium tax credits apply. They will have a cap for you. They also tend to have pay periods for certain.
Yeah. So dental is like a whole other can of worms, and like we're actually going to do a lecture on this in March. I think that's our topic for March, is talking about dental. And if you sign up for a dental clinic, which you'll learn more about our clinic options later today, then you will learn more about what it means to be kind of counseling on a dental side of things. But definitely explore this side of the healthcare.gov. So when you first click into healthcare.gov and you say see plans, it'll just show you the health plans. But what Dorian is saying is that you want to go to dental plans right here, and then you can see there's no premium tax credits, whereas on our health plan, this person was getting premium tax credits, right? And then dental plans also have those limits, and there's no really like standard way of looking at things. It's really annoying. You have to go to the plan brochure. Have to go to the plan brochure, or I think you can click here usually, and there's some minimal information, but right here, this is the most basic plan. It's the cheapest one that we see on the web, and there is no charge for routine dental care in network after deductible. Out of network is a different story. And then basic dental care, major dental care, and orthodontia is not covered. So basic dental care is not covered. Like, that's kind of crazy, right? So that's not maybe a super helpful plan for a lot of people. And then some plans where it does cover things like major dental coverage, it'll say waiting period of 1 year. So you need to have the plan for an entire year before they then start covering you. So dental is like a whole other can of worms. They are just, they don't have these regulations like healthcare does with, because they're not in the ACA. Yeah, Neil.
In dental care, like your yearly checkups with the dentist.
Those 2 annual checkups, yep.
Just basic, like filling.
We'd have to see what the plan considers those 2. So you would go into here. You can see all the waiting periods right here. So these have none. Some of these services are just not even covered. Somewhere it'll say something.
If you scroll, it's like 2 is the base.
Oh, the service class, thank you. Okay, so 2 is the basic. So simple extraction, fillings, and antibiotic injections. That was basic care, not covered. And then everything that's a 3, not covered. And then obviously orthodontia not covered. Dental is just a whole other story. But anyways, let's go back to this. What other questions do you have when you're looking at plans here?
To prompt you guys, like what if someone was like, oh, I take usually insulin. How is this plan gonna cover that? How would you go about checking that?
Would you all find out when you were digging? Or you can look on my screen. Is there something that you think we could do?
What do you think you'd click?
Yeah, Neil. Plan details, sure. You can do plan details. Yeah, so exactly. So there's a quicker way to get to that exact same spot, which is also just typing right here, add prescription drugs, which gets you the same space. I know nothing about drugs, so let's just start with insulin. Insulin's a little complicated though. It's like a whole situation. Is there another drug that people can give us? What was that? Whoa.
Atorvastatin.
Oh, Torvastatin. Okay, is that good? Let's try that. Okay, all right. So let's say we're gonna add this 10 milligram oral right here. Okay, and now when we're looking at these plans, we can screen by if that drug is covered. So we can see right here, check, that one's covered, covered, covered. Is that a pretty basic, is like, what is it? Blood pressure? Something, I don't know, something basic. Cholesterol, okay. So probably most plans are gonna cover it. Whereas something that's a little bit more niche or rare or expensive, maybe the plan won't cover. So you would like to put those in, especially if a consumer is really considering a plan. Yeah.
How are you getting?
To this page?
Yeah.
Okay, so when I went into the healthcare.gov/C-plans-, #, And I filled out all the information. I put in my information for now, and then I just put in 25,000 to show you all it's just above the Medicaid income. And then this is what we get as my premium tax credits, right? So if I start to view plans, I can see that that $361 tax credit is applied to each plan. So this plan was originally $330. It's now $0 a month. There's no like you don't get the extra money, but it makes it zero.
Yeah, there's no way to like really browse that I know of until you've actually entered some personal information. Unless you can look at just like.
You can just
Yeah.
browse. So what you can do instead, if you don't want to do all of this, is like, and sometimes we do this because we don't want to okay, what was I saying? We don't want to like go through the whole thing with the questions and everything, but we just want to show them some plans or maybe look at what's going on. You do have to put in a zip code because they are zip code
Oh,
related.
yes.
But you can just click see full price plans and not go through any of the questionnaires. And then now everything just doesn't have a premium tax credit applied. Other things I hope you all noticed was that the title of plans has a lot of information in it. So this one says it's HSA eligible, which we just talked about. This one says 3 free PCP. Does anyone know what that means? Table, yeah. Yeah, so 3 free primary care visits. We'd probably want to go to the plan and see what that actually means. Does it mean in network? Does it mean telehealth? Like what exactly does it mean? But that's pretty descriptive. $20 tier 1 medicines. And this is with UNC Health Alliance. So that's also sometimes really important, right? Based on where people are located. You have another question, Neil?
Yeah, does Medicaid and CHIP cover dental?
CHIP does.
Medicaid also.
Medicaid does too. Yeah, Medicaid does too. I thought you said Medicare. Actually, I think Medicare does too.
I think it for Medicare, it's one of the parts, but it's not, it doesn't come with.
It's not
Part B or
Part
A,
A.
Yeah.
It
Yeah, you have
doesn't?
to get, like,
Which
Part
one
B.
is dental or is it a separate?
Yeah,
Oh, so C, is that C?
it's, I think.
Is that C? Because D is prescription, I think.
Yes,
Yeah.
yes.
And you can be eligible for both Medicare.
Yes,
Yeah.
Medicaid, if you have Medicare, helps pay for your Medicare premiums. So there's like premiums associated with Medicare, Medicaid represents the costs of those, so you can have both at the same time.
So basically, if you're over 65, but you're also low income, then you can get Medicaid. too.
And Annika will talk about that in a bit.
Yes, your name?
Michelle, can you use your like HSA funds to pay for this?
Ooh, I have no idea.
I don't know.
We'll have to look into that.
Yeah,
Yeah.
good question.
Michelle? Tell us when you find out.
Google that.
Okay. Other things is you can add doctors and facilities. Again, something that can be really important. I have a story of working with a client. It was December 15th at 11:30 and we were still trying to decide their plan. And that's an important day and time for you all to know because that was the last day that they had to sign up for health insurance for it to start on January 1st. And they were very adamant that it will start on January 1st. So we're like, all right, let's get this done. We closed the clinic. They shut off all the lights. They're like, you all need to leave. And finally she chose a plan, but she was really between a plan that was better for her needs, like financial wise, but it didn't cover her provider that she really liked. And then there was another plan that did cover her provider, but it didn't really meet her. It wasn't like exactly what she wanted financial wise. So she was really between those two and we had to help her make that decision.
This seems like a good place to mention, and I'll probably mention this several times again. We don't advise on insurance plans, so when you guys are browsing the marketplace together, we're not like, hey, you should apply for this one explicitly like that.
Yeah,
That's
we
not
don't
what we're
tell
doing.
people what to do.
Yeah,
ever.
we are educating them on their options and allowing them to make the most informed decision possible based on the information that we give them, but we're not making that decision for them. So yeah, I think that's a really important point because I think naturally it's like, oh
Yeah.
yeah, no, this is the best one.
Yeah.
Like we should never be saying
Trust
this
me.
is the best one. We're saying these are the plans, these are the options. Let me explain them to you thoroughly so that you can make a decision.
Yeah.
So yeah, just keep that in mind.
And you'll sometimes get tricked because patients will be like, well, I don't know what to do. Like, what would you do? What do you think I should do? And it can be really easy to be like, well, I really think this is a good plan for you. But instead you want to be like, well, I can't tell you which decision to make, but we can go over some of those requests that you had in your plan. Let's talk again about your pros. What is it that you definitely want to have in your plan? What is it that's their top priority in your plan, right? And then kind of help them from there, but they have to make the decision on their own. That's actually super important as being a CAC. You can get disqualified as a CAC. Yeah. Graves?
Yes. So when so you can't like outright like try to convince them to do one plan, but can you kind of like emphasize the benefits of like one plan over another?
If your intention is to get them to sign up for it, then no, right? Because that's the same thing. It's just disguised in a different way. If it's because you think that that was not covered, or they're like, maybe I didn't explain it well, or there was this explicit question about, wait, what are the benefits again? Then absolutely go through that again. It should never be a rush process. It like, it can be sometimes a little bit discouraging because this just takes so much time to do, right? It takes a lot of time to work with people, but it is so rewarding at the end when they have made a decision that they feel really happy about. So you'll learn, we're not a clinic that meets with a patient once and then like, bye, see you later. They come back to us often. Yep. And we will keep working with them until they've made the decision they are happy with. Okay, I think I'm gonna go grab people's lunch. But you all want to take over from here? Okay.
We're gonna pass it over to Annika to now dive into Medicaid. And give all the details about that. We've already like talked about it a lot, but now we'll go over it more formally. Where it should be already, isn't it already pulled up? Yeah, on this. Where? On here? Oh shit. Okay. Oh, no. No, I don't want to click through. Ugh, how do I present from slide? Oh,
A little icon. Actually, I think right now, let's take like a 5-minute break. That was a lot of info. You guys have this chill for a second and then we'll get into it. Yeah, it's just. I don't want. Yeah. This is really. I know. Yes. I see. I do know. And it's gone today. Yeah. Nobody did well on this. Yeah. Still, but also. Yeah, no, I don't.
Line everywhere.
Yeah.
And I was like, I'm not. Smells like. For the first thing. But she did. Yeah. Like she had the carpets covered. Like she got like a. Went to the body trick. And like the room smelled great. At first, I was like.
I am my like home address.
I don't know. I just know too many words and they all spell it last names different. Oh, you got it. And we all spell it like. Nothing about the first line, something. Yeah, I know. Plus, it's also expressed and Jimin's coming. Oh, you. No, 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 he did not say. What happened? How we go? Yeah. That's what I didn't know. Oh. I asked her, I was like, yeah, like I'm. Yeah, like I'm not. I'm not really just being. Making jokes on America. Yeah. Here. Because I was really encouraged. I was running my gym and wanting to go. I wanted my gym and wanted to go. So I didn't because I'm not going. And I come back from that. I was like, oh, no, I'm 22 now. But okay, whatever. That makes it odd. I don't know why he's saying that. He's like a heart. I don't know that. Like, I think one of those. I was X-ray.
All right, guys. 12:30, we're gonna bring it back in. Yeah, let's get into it.
So Zara already gave you guys a pretty good background on Medicaid. But as she mentioned,
Actually, I think we're missing 2 people.
oh, I'll wait a minute.
Yeah, let's wait like 2 seconds. Okay, we're gonna start now.
So the example on the side is for ages 19 to 64 who are low income. And these were the people previously left out of Medicaid before it expanded. So there'll be different income limits based on falling into one of these categories. So the income limit for ages 19 to 64 is the lowest income limit. And as we already mentioned, last year, December 1st, Medicaid expanded, woohoo. So that increased access to Medicaid for 600,000 people in North Carolina. So previously you had to fall under one of these categories. You'd be pregnant, child under the age of 18, have an official disability, be blind, caretaking of a child 18 or younger, or be ages 65 or over. And that's the dual eligibility that we mentioned earlier for both Medicaid and Medicare. And these statuses sort of align with the differing levels of income that I mentioned on the other slide. So before Medicaid was expanded last year, these people that were 19 to 64, not caretaking of a child, not pregnant, they were considered in the Medicaid gap. And people who didn't qualify for Medicaid but made less than 100% of the federal poverty line would fall into the Medicaid gap. And they would not be receiving any of those premium tax credits. And as you saw on healthcare.gov, the premiums are around like $300, $400 per month, which is totally unaffordable to someone making less than 100% of the federal poverty line. And Verena drew us a beautiful, it's gorgeous, little, not timeline, but you guys know what I mean. What? Yeah.
Anyways.
It's pretty. So as you can see, after expansion, people making 138% of the federal poverty line or less will qualify for Medicaid. And then people, before on a side, we had 100% to 400% for premium tax credits. It's actually 138% because you can't get premium tax credits for Medicaid. It's free. So people making 138% to 400% to above 400% will qualify for premium tax credits. And then the cost sharing reductions that we mentioned earlier, that'll be 138% to 258% of the federal poverty line.
So yeah, really quick, can someone raise their hand and tell me where on this, where was the gap? Where was the Medicaid gap pre-expansion? So, okay, so pretend qualify for PTCs was up to 100, because we were talking about how 138, this is after expansion, right? Because now these people would be qualifying for Medicaid. So we'll say up to here was PTCs, okay? I'm gonna extend that line. And then Medicaid, right, covered under this for what groups of people?
What group was
Underage, one
left
group.
out?
The other ones, there was blind, disabled, so who's left out of this picture? Childless adults, people that don't fall under any of the special categories, but are making less than 100% FPL and don't qualify for any premium tax credit. So they're basically left with no option because nothing's affordable. So yeah, the Medicaid gap was like zero, or no, sorry. Actually, how can I best draw this? Actually, I'm just gonna leave it as the arrow, because it was less than this for certain groups. Okay, does that make sense? Because this is really important, because like, some people are probably gonna come into clinics still in the next couple of months being like, no, I applied for Medicaid in the past, they rejected me because I didn't fall under whatever category. We need to be able to explain why that no longer applies, okay?
And this is super important because people that aren't aware that they qualify for Medicaid, they're not getting between 100% and 138%. They're not getting those premium tax credits. So now their premiums, first of all, they like shouldn't be in those plans, and their premiums aren't being reduced to an affordable amount per month. And that's like pregnant women, right?
For what?
Or like, isn't it just certain groups didn't roll over?
Wait, what? Huh?
For pregnant women, if you were on pregnancy Medicaid,
I don't know. The woman that came and talked to us about expansion was like, there's one particular group and I can't remember the group
One particular group that what?
that like didn't.
It might have been
Bro-
pregnancy, because
okay.
those requirements have changed, which we can kind of touch on that later too. What were you gonna ask?
So like before expansion, if you're a childless adult, you had to make less than 35% of the poverty line to get to. Does that make sense?
you actually wouldn't qualify for development.
You wouldn't qualify. So there was, Annika used the term, it was dual eligibility. You couldn't just be low income. So your income wasn't enough before for Medicaid. You had to be low income and you had to fall under the category of one of those special groups. So like blind, disabled, caretaking, a minor, one of those groups that we described. That's not the case anymore. Now you can just be low income or meet the Medicaid income requirements and apply for Medicaid. But that wasn't the case. I know it's really crazy. That's probably why you're confused.
I really, before today, I didn't know that. Like, I thought.
Yeah.
Just low income, you could qualify for Medicaid.
Yeah, which is, I mean, I think that's how it should be, and thankfully that's how it is now, but it's really crazy how like there was an entire group of people that simply could not pretty much apply for anything, because they didn't meet those requirements. So Medicaid expansion, it took a long time because a lot of people were pushing for it. But yeah, thankfully that's not the case anymore. Does that make sense? Do you have any like
Yeah,
clarifying
like-
questions?
If you're like a homeless adult, you wouldn't qualify right, in the past.
Yeah, that's
Yeah.
Now anyone who's less than 138 will qualify in, right?
Exactly, yes.
Basically, if you were a US citizen or anywhere here.
Yeah, which, yeah, we're still gonna have to have the whole separate conversation about immigration, which is really, really important for our work because we work with a lot of undocumented individuals. We won't get into that right now because it gets like pretty confusing, but yeah, we can answer questions about that as they come too. All right, sorry, I'll go back to you.
No, you're good. And this is just another, almost as pretty as Marina's drawing.
No way, no way.
So it shows you, yeah, the people making below that 100% of federal poverty line and not qualifying for Medicaid were in that coverage gap. And okay, I'm switching it over to Dorian now to talk about
Medicare, we love Medicare. We don't actually work with Medicare that much, but Medicare is our joint federal, well, no, it's not joint. It is a federal program just for people who are above 65. They have a Social Security recognized disability, or they have one of these two diseases, end-stage renal or amyotrophic lateral sclerosis. And they have to have paid 4 years of their FICA taxes, so Social Security essentially. So that is, yeah. That is what that is. But we really don't work with Medicare that much. Medicare is very complex in terms of the parts that are offered. Generally, people who have paid into Social Security for 10 years or more, so that's 40 quarters, they are offered this Part A part premium free. This is just hospital insurance. This is for all inpatient services, like hospitals, like rehabilitation centers. That's what skilled nursing facility kind of is. And then Part B is supplemental to that. Not everyone needs that, but a lot of people do end up having it. It's for outpatient visits, so like doctor's visits, things like that. And then the other one that's purchased in alignment with all of this is Part D. That's for prescription drug coverage. And so people normally purchase A, B, and D. That's traditional Medicare. Part C, this is the one that is a little bit separate from everything else. This is Medicare Advantage. These are, for all functional purposes, the same thing as A, B, and D, but they have extra benefits sometimes, like vision, dental, and hearing. And they also sometimes have a couple other fun little cost sharing like limits that are make them a little bit better than A, B, and D. We don't work with Medicare that much, so you don't really need to know too much about this. You can sometimes patients will come in and they'll ask if they qualify for that. And it's just important to know that if you've paid into your Social Security for that much, they'll qualify for Part A, and then all of these other things you can explain to them, like what these parts mean. But we're not the most qualified to speak on Medicare specifically, so we do a lot of referrals to, say, Department of Social Security or social services in the area. They're much more qualified to handle this sort of thing. So yeah. In terms of applying for all of these things, healthcare.gov is meant to be this one-stop shop where you can go and apply for marketplace applications, but also determine eligibility for Medicaid and CHIP. And so if you go through that same process that we went through, I mean, you just went through the eligibility screener, but if you actually made an account, you submitted all your income information, your immigration information, your family size, you can also have an assessment for Medicaid and CHIP there as well. So we recommend that for all these applications, for Marketplace, for Medicaid, that we go through healthcare.gov. Medicare.gov is for applying for Medicare. There's a specific open enrollment period for that as well. We don't really touch on that. But yeah, people who are eligible will be contacted by that, and normally that process is handled separately. So yeah, that last line there is very important about connecting to other offices. We mainly handle Marketplace, Medicaid, and also our local financial assistance programs.
Yeah, so generally speaking, if you're ever in a situation where you're like, this feels out of my scope, like this feels out of the scope of what I know and what I can like confidently educate the patient on, that's when it's really important to be able to recognize that and connect them to a different resource, because that's not you like failing in providing them a service. That's you just connecting them with the right resources, which is incredibly valuable. So just definitely keep that in mind. Don't think that that makes you like you're not helping them. You're still being very helpful by just giving them the right resources. And then Dorian, could you touch a little bit more on like what actually a Medicaid application would look like what things you have to provide, something like that?
Sure. So the Medicaid application itself will use the same application as healthcare.gov for Marketplace. So the first thing you need to do there is create an account. They'll have some questions there that will confirm their identity. This part is really crucial because if you can't verify that it's the right person, then it slows down the process a lot. But they'll ask for some things that are related to their tax returns because they'll enter their Social Security number in there. So you'll first do that bit about identity verification, and then you'll need to answer some pretty basic demographic questions and also some questions about your income. So monthly and yearly income. I forget which one of those is actually used for Medicaid. I believe it is monthly that they look at. Sometimes there's a difference, but you'll enter that. There's some deductions you'll enter in as well. You'll enter in your immigration information, and you'll also enter in your family size at some point. It's good to have for these appointments when you have them with your consumer that they know, like they don't need to submit any documents for these applications for Medicaid and Marketplace. It's only if they ask, but it's good for them to know their social security number. It's good for them to know what immigration documents they have if they are not US citizens, because there are a couple citizenship statuses that are eligible for this sort of thing as well. So it's much more intuitive when you actually look at the application itself, but yeah.
And like, you don't have to memorize all the parts of the application, just having a general idea of the information they're gonna need to provide is helpful, because they may ask you that before you actually get started going through the application. But like Dorian said, you're prompted, as you go with all of this, so you don't have to like memorize it all.
Yeah, so, yeah. Anyone have any questions on that? Cool. Oh. So A is the only one that you will be automatically enrolled in if you have paid your taxes and you turn 65, you will be enrolled in the hospital care plan, basically. B is actually kind of like sold separately. A lot of people will get B, but B is not automatically enrolled, right? So B and D are both those add-ons. A lot of people end up getting that sort of thing. And C, a lot of C plans will bundle all of those things together. Yeah, that's generally right. C is actually like all of the other things, just delivered a different way. Also, good thing to note, if you just have Medicare Part B or Part D, that is not minimum essential coverage, because A is the one that is the most important. Yes.
So someone was saying that if you're low income over 65, you need Medicaid, pay for Medicare premium. So for everyone who's over 65, pay taxes for 10 years, they all get paid like completely free, right?
So Medicare is much less comprehensive as a program compared to Medicaid. Once you start looking into the details, you will find that a lot of folks will struggle with out-of-pocket costs from Medicare. There is no premium for Part A. This is true, but there is still deductibles for Part A. There is deductibles for Part B and D. There is premiums for Part B and D. And so there is a very limited amount of things that are covered just by Medicare alone. So that's why so many people who are also low income will be also on Medicaid, because Medicaid is much more comprehensive as a program, and it can also help you save on a lot of those costs related to Medicare if you are also eligible.
Yeah, so when I said earlier, Medicaid can help you pay for your Medicare premiums, I was referencing your Part B premiums. So the ones that aren't $0, your Medicare Part B premiums, you can get assistance paying for that if you are low income and qualify for Medicaid. But yeah.
Yeah, so like if you're low income on Medicaid and Medicare, I guess like if you optimize everything and you use your Medicaid paid for like the right things, you end up coming out with more coverage than what you would be on just Medicaid. Like, is that the advantage of doing both?
It's possible, but like I can't think of many services that would not be covered by Medicaid. So
Like, I guess what is the point of being on Medicare if you're already on?
sometimes I think based on program design, you can't use full Medicaid that way. You would have to use them as subsidies for Medicare.
Oh, like,
But
if
we,
they just do what your government just makes you both optimize.
well, you're just on both, but it's, I think you use one as, the primary payer. Medicaid tends to be the payer of last resort, which means that if you have another form of insurance, that other form of insurance will be used first. So you might get some access to new services through Medicaid, but most of your insurance would be paid through Medicare.
So when you have Medicaid and you have Medicare, Medicaid is serving a different purpose than if you were to have full Medicaid, because that's your only form of health coverage. So when you have Medicaid on top of the existing Medicare, like Dorian said, Medicare is what's like covering your pretty much everything, and then Medicaid is adding on stuff on top to reduce those costs. So it's serving two different purposes depending on the individual.
That's confusing.
It is, and it gets confusing, so like, definitely, if you guys like, forget everything we're saying right now, we have primers with all of this stuff summarized, which will like show you guys where to find those resources. Also, like, don't feel embarrassed to like have to look stuff up. This is all, very, very normal and okay.
Yeah. This is a really great training session, but we don't really expect that like you come away knowing all of this per se, nor that that's the most relevant to what's in clinic. This is just so that you have a good understanding in case you run into questions in the clinic. Let's move on to a lovely, lovely topic here on patient privacy and safety.
So first thing to do during a patient interaction is to make sure that you have their consent to ask these personal questions that you'll be asking about income and family and possible medical needs. And to assure privacy, just make sure that you're having these conversations in the room with the patient, not like out in the hallway where people could overhear. And ask for as little protected health information and personal identifiable information as you need to carry out your responsibilities to guide them through healthcare applications or informing them about their options. And like I said before, make sure that you're aware of the location that you're in. Just avoid public areas for private questions. If you notice a breach of information, report it to your coordinator for the night or another person. And your modules will get into the details of this, but protected health information, laboratory test results, you'll see this on a patient's Practice Fusion. So make sure that you're also opening Practice Fusion in an area where you're not going to expose their PHI and PII.
And Practice Fusion is like the EHR
Oh, yeah.
that we use, the electronic health record. So this is like where all the patient charts are basically. That's what that platform is.
So you guys, it's pretty common sense not to expose patients like this. When you're talking with your GCC colleagues, don't refer to to patients exposing their PHI and PII. Another thing, like don't take notes in your notes app or anything. Make sure you're doing that inside the electronic health record, the Practice Fusion. We'll send you guys the HIPAA certification later, which will go into PHI and PII. So this is what will be
Just
sent
skip that
out.
slide. Okay, a couple of other quick notes about that stuff. So like we, since we have like different since we have like different volunteers going into clinic each week and stuff, there are a lot of times where you're gonna have to talk to another volunteer about a patient that you're working with and stuff. If you're texting about it and things, there's like a patient record number. That should be the only identifying information about that patient that is ever in a text message. We're actually working on getting on this platform that one of the other branches use to communicate about this kind of stuff. So maybe that'll change, but for now we can often communicate via text message. So just make sure really that nothing is mentioned there. And then saving documents is another big thing. So we collect when sometimes helping with applications, some documents from patients. Those should never be stored on your personal devices, because a lot of times that contains, their name, their number, a lot of other personal information. That also needs to be stored on the EHR, the Practice Fusion health record. So yeah, those are just important things to keep in mind. And obviously we'll remind you of that when you're actually in clinic. But yeah. Okay. And then it's almost 1.
Should we do discussion now?
What was on here? Sure, yeah, we can do this real quick. Patricia was in clinic last week and worked with a patient that has a follow-up, but Patricia will not be in clinic. How can she ensure that the patient receives the best care with the volunteers in clinic tomorrow while protecting the patient's PHI and PII? Who has a good response for this? Mhm.
Gonna put the patient's record number on in chat and talk about the patient that way, just with the record number.
Yes, exactly. So this is what is just described as like very, very common. So like Megan will see someone on Wednesday, and then she texts me, she's like, hey, I just scheduled them for a follow-up to come in and see us again the following Wednesday. This is their MRN, and like she gives me a really brief synopsis about what they talked about and what they need help with. This is obviously all also on their chart so that I can refer back to it. But yeah, she sends me that quick text to make sure that I'm filled in on the patient and doesn't mention any of their PHI or PII other than the record number. Yeah, so perfect. Okay, I think it's pretty close to 1, so we can just go ahead and transition to lunch. Yeah, we already talked about all of that. Yeah, okay. Any questions though before we do that? Anything at all from what we've covered up to this point? Cool, you guys have been doing awesome so far. Okay, can you raise your hand if you ordered?
Well, I just didn't want to like. Well, yeah, but I could be like, so I was like, then like, I don't know.
It might be outside if you guys want, just so that we can, it's really nice out and to keep the room clean. Anyone opposed to that? Okay.
outside, or there's some people sitting in there out here too?
Because our high school.
Yeah. Can we both like here, like public forward? Is that weird? What? This is good. Yes. So we like the whole time, just. Are you fun? Yeah, I'm grateful for 2 hours away. For ECU. Uh-huh. You guys have a frat party. I think that's the first time I saw you. Oh my gosh, like I do, we've been to, oh yeah. Dude, that floor is crazy now. This room is all, I always hear stuff going on in the hallway, like, apparently, like, they have. Like, toys or stuff up there, very loud. First time I met Shadi, he was like, Shadi's parents' house. His name is Shadi? Shadi? Shadi. Yeah. And then said Shadi. I thought it Shadi. Yeah. Shadi, okay. He was like telling us, I don't know if they used to, they used like a car park box till it. Oh. Yeah. I'm surprised that he has the lights at all. I know, I told them, I like made them put tape over it. No, you are good? Yeah. I don't know, it's, yeah, they're fun. That. Well, my friend, her boyfriend is like next door. Okay, yeah, and like, they'll like yell at each other through the walls. Yeah. He's crazy, guys. I thought he was like, I don't know, I was just like really scared by him when I first met him, because I just like didn't understand Tony. Oh, yeah. Cause like they used to know there. He also. So. Or the good one. Yeah. You got like a shirt and all. My best friend. But it was just never really like, and like a lot of his family knows now, but in the beginning, like, they're like really strict about. But yeah, just never. I think most of the stuff wrong. You know. But I don't. Well, no, thank you. It is still. We even went to like something. So there was other guy. I thought you and Jay were like best friends. We are not best, which is why I never talked to you about. Wait. I see him all the time. He has slide over my Instagram stories. Does he live in Franklin? I don't know. I don't know anything. What's his last? Yeah. Okay, I'll tell you guys. Basically, you probably heard. He's also But, so really
I'm
like.
sorry, can I go over that name? Like, wait, is that his like birth given name Shabby?
Shabby Garage.
I don't know.
From,
He did wear.
yeah, that's like a bunch of like, stuff like the universe, right?
No.
Probably. I feel like they keep saying that.
We know the same people. I know probably like next to your people.
But, anyways, they were like best friends, like, I knew that was me, they were best friends. Then apparently, like, he is a really toxic. He's like one of those like. So, he basically kind of slipped up and told Rich, like, oh, I cheated on bio exam, or basically the TA like showed him the exam for. What? Yeah.
Was he fucking with you or something?
No, he's gay. And then with the girls, yeah, like.
But like, why would they do this?
Why would this gay?
Yeah.
He was like stressing, he was like, kind of like, very like, oh, like I'm so stressed out, anxiety.
I would
like.
yeah, I would like. Yeah,
That's
helps.
how-
No, I would go
Like,
Caps. Yeah, go Caps. I would say that.
But yeah, he's so manipulative. But basically that happened, and he has that like on it. He has three things on his record, and it's all for Jake.
Is this the person that you were saying is gonna?
That's what I thought. So yeah. Wait, how do people like find out about?
Because he told him.
He told Rich, and then for because Rich was like, "Bro, that's not fair." They're all in the same bio class, and like.
Also, that's like so different. Like having a TA. Also, TAs are paid. So it's like, what incentive does the TA have? Like, you know what I mean?
You're both friends.
The
Oh,
TAs are grad
yeah.
students. Like, it's so like,
Unless he's like.
there's a really, to me, there's a really big difference between asking a friend, like, oh my god, like, like, what was on the exam? Like, can you give me, like, can you, like, tell me, like, whatever? Versus, like, actually showing you the actual test. Like, obviously, both are, like, bad, but, like, the first one happens. Whatever.
Oh yeah.
But, like, showing you the test is, like, imagine if you got, like, a different version of the test. That would be fine.
But he got away with it.
Well, good, not. Well, aren't for that.
But they heard it.
Why?
I don't know why they cleared it. I feel like it was more than 3 years long. And then he had some kind of report from his first roommate, and then some first roommate, except that he like hit him. The second roommate, which is Rich, he would like call him like, he was just being like super like this, call his parents like slaves.
What?
Yeah.
Good one.
Wait, that's actually. He moved down. Moved down on top. It's very weird. If we get into HBM, or when we get into HBM, we'll do it. Did he get a shirt wall? He did. I don't know. We'll need that for time. Oh yeah, like that's so crazy. Like, that's our bed, and he was like, oh, I'm a shirt. No, what's your admin? Or I was like, that's like the only thing. That's the first thing. I'm not even joking. Like I feel like when I ask a lot of people, like I've met some people like in HBM, and like biostatistics, nutrition, environmental science. They go say like, oh yeah, I'm a shirt.
Well, Rod knows.
Well, the only people that I know, like,
Rod, yeah,
like, are talking about it. Like, oh yeah, like I applied. I was there, so.
Yeah.
When I like applied, I didn't even know. Like I couldn't know. I don't want to share it all. I didn't know that. I didn't know. UNC was good for public health. I just like to know. So I didn't even try for it. I applied here for public health. So. Yeah, I don't know, but you heard moments. Older brother, Shaddy's older brother. Yeah. Actually, I met his brother before I got shot. Really? Because I was networking. Oh, like this was like networking. Dude, I love networking so much. But I saw that he was like he was like doing really good music. At that time, I was like, oh, wow. So I like set up like a meeting with him. And he's like, oh, yeah, my brother's Nice, nice. Alright, then. I look up the cute. Wait. Okay. You know it?
That's from Shaggy.
Yeah. Yeah.
I've heard the name a lot recently. And he's the one that got the, okay,
He's the one that
Shaggy was
got-
asking him about that. Okay. Great stuff.
It's so good. I like that.
We're going. Yeah.
So really cool. That's what it is. That was his beat. Yeah.
I did not get one because that is a fancy way of saying I. where am I getting-
That's so funny. Yeah, we have. I went to like this big like Indian thing and I saw Monica.
That's funny.
And I remember when I was spring, I met Donica eating Swish. And
But that's crazy.
yeah, and then I remember asking about each of them and he called you walking. Like, his name, I don't know.
Oh, he called me.
Like asking about a client or something like that. But I literally just started to figure it out. So funny how many people I know like through you. Because I saw
Andrew's.
like I saw Donica and then I saw you and I just was like, wow. And then Shivani's in my econ class and Caitlin is a debate in high school. So I know her from that. Yeah. So like it's like such a small world. Like my other friend that like is also a rock sister. Of like yeah. Also, like through my moss, I know like some like one of my friends' boyfriend also right now. Like, you know who Sean is?
No.
So like I met him at like wow. Yeah. Thing.
We all do.
What major is Zara like? Yeah, what major?
Zero.
Talking about how like yeah.
Well, I was supposed to do it last semester, but I wasn't in teams.
Oh, yes, yes.
Yeah, that's right. So that was really unfortunate. November 3rd.
Yeah.
Yeah. Yeah. But I think that's part of why I think that people are getting out and just today's my birthday, but I didn't realize they asked for like my social security number and stuff. So like I didn't realize that it was like a government, like I thought it was just like an account, yeah, like, oh, like, you know, like how when you're shopping for something or whatever, yeah, like they like, oh, you're above the age, whatever, blah, blah. But then, they asked for my social security number and that. So. But yeah.
But I guess it depends. Like it's alcohol.
Yeah.
That's good.
I like it. But that's still. So it's like, I like that, but also like.
And so technically I was learning about healthcare system. That's so so I think it's a really good training that way. It also is like really fleshed out program. It has really good mentoring, like faculty mentor, which can be really good. I think she's really well organized, at least compared to yes, like they don't do as often as that's faculty. So, but it's less mentoring. So we have a good that's really important, especially that requires so they have so people get placed so I think there's a really good structure. So
It's, there is a really topic.
it's just like, it's not more like. The city of Rock.
I think that's good. That from your, well, personally, I think it's like,
Like, at least like.
I know. Now it. But most people.
Like, never like, I don't know, maybe because I don't, you know, it's like, I like kind of gone into that, so, like, before I got never like that. But like, these kind of geared me for mostly, you can have a skin, it can still apply. Because he doesn't like, but he's just told me like, oh, like, even if you have like, supply and everything you can. So like, right now, I don't have like set on there, but I do have like. But I'm trying to get that. Yeah, so it's like, it's literally. Yeah, I looked at that one, but then I was like. They have different locations. Like, I was thinking like maybe check. Yeah, where I live, it's scary because like, yeah. Area. So it's like. Yeah, there's a bunch of places. I tried it now, I asked her, I was like, oh, I live like my neighbor. And then you. Oh my God. No, maybe I have no, maybe it's a state bar. You know, like. Oh my. Oh, you found out, okay. I knew it's for you. Okay. Yeah. Mine was the first. Already.
Okay, I'm trying to see. Forgot about that.
Oh, Benito.
Okay, yeah, I think. So module 6 is all of this, but then module 5, we already talked about all of this.
Just for practice.
Yeah, I think it's just more practice.
And what they mean.
And Dorian actually touched on this already when he was talking about Medicaid applications, since that's
Why
on.
don't you review this?
Okay,
Join it.
yeah, I can do that. Should we do another practice?
Okay, while we are coming back together, we would like you to work on a reflection.
I love the look.
This thing?
No, the packets.
Oh, yeah, no, I hopefully it's helpful.
Okay, work on reflection 2, which is on training session 2, third page on the back.
Okay, oh yeah, good to see you, Dorian, thank you.
Next one?
I'm on med clinic for the next 2 weeks.
2 weeks, okay.
Okay,
I'll probably call you.
Why is that?
We just had some things that we did it.
okay, so should we do another practice scenario or?
Yeah, what is 7 to 8?
7 is culture.
Yeah.
And then 6 was,
6 is one of them.
so these are like all tied together, and then 8 is, so this is
So
all,
the 3 of us can split up 6.
okay,
You're gonna do 5? What do you want?
5, oh yeah, I can do 5, yeah.
Wait, which one do you want? Or honestly, like, we could have one person comes to that and then.
I think that's a good plan. Do you meet like all 3?
I know that they are.
Okay,
Unless you, can you split? Can do some.
yeah,
I'll do
yeah,
6 for sure.
yeah, we can do that. We can, okay, I can do 5, you can do 6, and then we can like decide how to split 7 and 8. Do we want to do all 3 scenarios?
What, sorry, let's. Let's. Oh, wow.
Okay,
I feel like if we're dragging.
yeah, all right, sounds good. All right, guys. All right, guys, we're gonna bring it back in and keep talking about marketplace related stuff, and then do a little bit more practice, since this is a really important part of what we do. So we're first going to talk about like creating an account. We already covered like the plan categories, and then we're just going to do a couple more practice problems. So Dorian already touched on this when he's talked about making a healthcare.gov account, but there is this identity verification that you have to go through. And so listed here are like the documents involved in verifying your identity. So this is just something to keep in mind. I won't talk too much about this since he already covered it. This is an overview of the like enroll to-do list when it comes to marketplace applications. So obviously you're going to start out with that window shopping tool questionnaire, fill it out with like as accurate information as possible, look through, evaluate the plans, the available primary tax credits, and then go into their more specific needs. So the stuff that we talked about with the prescription drugs, do you have a primary care provider that you prefer? At this point in the conversation is where you want to start asking them about that information, compare and help them navigate that, and find a qualified health plan. And then, you know, assist them in like selecting coverage. Again, their decision, but we're helping them navigate the platform so that they can understand all their options. And then make sure they're really well informed on their plan, review it, and go through that summary of benefits with them. And then they leave feeling really confident that they know how to use their health insurance. So that's an overview of like what it looks like from start to finish, helping with a marketplace application. And then now, oh, actually, just kidding. These are some other questions to remember to ask. And these are things that will be prompted also on the questionnaire, but does their employer offer health coverage already? This is a really big one. Sometimes that's the case and they're just unaware of this. So ask them this if there's a way to get more information from their employer about what options they have. That's something you should ask. have they started the FFM stands for Federally Facilitated Marketplace? Have they started the FFM eligibility application process? Who's actually seeking coverage? Is it the person you're talking to in clinic, or is it their entire household, or who is not covered in the family? That's a big question that you need to ask. I touched on this in the previous slide, but what health plan features are most important to them? So maybe they do have a preferred health primary care provider, but that's not like super important to them. Like we kind of have to gauge in order to like best help them what healthcare needs are specific to that individual. So that's a really, really important point. And yeah, so same thing for 5, just really understanding the patient's unique and specific needs. Do you guys have any questions about like this overall process of marketplace stuff? Go ahead, Zara.
But, so when you're having, so we need you all some questions to consider or ask, and then on the shooting, what was it? Enrollment duty. So we're giving you like some information, some type of direction on how to get started. But I think the big takeaway here is that it is a conversation. We would ask often, what are the questions I need to ask? What are the steps I need to take? There's not really any such thing. That's why our training is so in-depth. That's why we'll continue to train, we'll continue to keep learning. I mean, you've learned today, I think even that not all of us don't even know everything. Point being that you have to have a conversation with your client. You have to just sit there and listen to exactly what you're saying. You have to ask questions, you have to probe, ask open-ended questions, you can learn more. But it's really, really important to really take in all that information before you go anywhere else. Because what happens is you take in one piece of information that, oh, they're under $20,000. And you start thinking, oh, Medicaid, that's perfect. Let's start going on a Medicaid application. You tell the client, you're eligible for Medicaid, like, let's get started on this. Turns out they're actually not, right? That is extremely disappointing to patients. We want to make sure that we're not jumping the gun. We're taking it step by step, and you have to start by step.
Yeah, exactly. Yeah.
And like, sorry, and it is really like, we're gonna have you give examples of what you're doing.
Oh yeah, absolutely. I mean, I think there's like countless examples of that where, I mean, there have been conversations that, you know, their options were like really limited and the conversation may not have ended like with giving them, you know, securing them with a plan or like them having like really, really clear next steps, but they'll be like, thank you just so much for listening, or like, thank you for like that's a really common thing, because this is a really intimidating part of just life, I think, health coverage and all of that. And it can be really, daunting to like kind of approach this when you don't have any information. Like I was just talking with this person in clinic last week, actually, who Dorian is about to go help right now. And he was like, yeah, no, I know I need to work on this. He doesn't have health coverage and neither does his spouse. He was like, I just have so much going on right now. I don't even know where to start. And he was like, I just feel like really overwhelmed and I just like need extra support. So just us being able to be like, okay, we're going to help you with this application. We're going to go through it step by step with you so that you feel like you have that assistance that you need. That's a really big part of it. It's not, like Zara said, necessarily having all the information. It's wanting to be that advocate for the patient and like help them get what they need. So yeah, that's an important thing to keep in mind throughout the entire training. Anything else to add? Okay. Okay, yeah, back to marketplace specific stuff. These are important things to remind your patient. So their enrollment generally isn't complete until the health insurance company receives that first month premium payment. So this is an important point. I think you already mentioned it earlier, actually, or did you?
Kind of mention it, but another thing to note here is that even if you have a $0 payment, which happens a lot, your insurance company will still ask you to do it. And that can deter people sometimes. It's just explain that this is simply there as a formality in a way. We know that their insurance bill will be $0 monthly. But it is a formality to add it in right now.
Yeah.
They're not.
Yeah. If they do miss any premium payments after that first month, the marketplace may cancel their enrollment, unless there's a grace period that was outlined in the plan or something like that. So keep that in mind. This is where it comes into like really making sure the patient understands what a premium is, what the numbers that they see when you're going through the marketplace application actually mean. So just make sure that they know that, and always encourage them to enter the application and enrollment information themselves. This is just, again, emphasizing that we're only a guide. And when it comes to that, actually physically, a lot of times when I'm going through marketplace stuff, I'll like turn my laptop to them so that they feel like they're the ones entering the information and they feel like, they have control over the situation. So I'll like be on healthcare.gov, I'll have pulled it up, I'll show them my laptop and they'll be the ones really working on that application.
That is actually the best way to do it.
Yeah.
You can put the laptop so that you can see it, and you can even ask them, okay, what is your age? Any of these options apply to you? When you get to like the eligibility and it has to be for the boxes that apply. You just ask them, do any of these apply to you? Do you want to go ahead and fill this out? I can have those with you.
Mhm.
Like, there should always the autonomy shift towards it.
Let's practice.
So that's a remnant from our.
Yeah. Grayson. Funny. Okay, we're gonna do Benito now. He should also be in your worksheet packet. Go back to healthcare.gov and we're gonna enter his information and see what comes up. Yeah.
Burping hasn't stopped.
One more.
There's something that was like, felt like was really.
Look out, an important reminder for patients. I don't remember. Maybe it'll come to you.
Oh. Sometimes you have to follow the train of thought back, you know what I mean?
Yeah. Wait, you remember?
Mhm.
What was it?
Because you were saying that it's important to make sure patients know the definition of premium and deductible. And I also wanted to say on the flip side, don't assume that they don't know. 'Cause
Yes,
that
this
can
is
be
also
advising.
true. Yeah.
And like, how do you navigate that? And like best practices, ask them, are you familiar with what a premium is?
Yeah, yeah. That's a good point. What's up? Is this a question for the group or? They're married. Oh, this came up in the last training too. I can't remember. I'm trying to remember what I told them to enter that for like learning purposes. I think, yes, assume that they're married. Okay.
How much are they making?
But that's a question, that's an important question, because it's one that you will have to clarify. So with all of this insurance stuff, then being in a, like formal relationship or whatever is separate from like actually being married versus divorced versus separated. Those are all their own specific categories that they'll have to indicate. So, yeah. What was that?
What is their income or what's the income?
They're probably. You can go ahead and put, I think 30s, 35 should be okay for now.
Okay. For both their joint income?
Mhm.
Probably 35,000 for their joint income.
Oh, wait.
Sorry? Should you add? Like, why wouldn't you? So age matters mostly for a few different key ages. It matters for 26, right? If you're on the cusp of 26, then that's something you need to find out. Does anyone know why 26 matters? Yeah, maybe some of the other parents insurance. It matters like 19, yes. Well, if you can't find on term thing about it. Give me one second. So 19 also matters. What is 19? you're not a child anymore, but if you're under 19, you're maybe eligible for Medicaid. And then 65, I guess, is the other thing, right? And that matters. Because sometimes I'll prevent that. So anything outside of that sounds, let's just assume that they're.
And we were like reenacting.
These are the notes that we. Yeah, so honestly, instead of browsing plans, I want to tell them. I want you guys to think about what questions to ask them, because I think that's.
Cause that was the
thing
key,
for me.
we
Yeah.
didn't want to.
Yeah.
And then maybe the reasons for that.
Yeah. Okay, so the focus for this scenario, so we remembered last time, yeah, the last time why we didn't have all the key details in this is because, yeah, let's do that. Do you guys want to move over here and sit with this table?
All right, we're gonna restructure this activity. Can one of you all move on this table? Someone on this back table? To the front one.
Yeah, so the purpose of this scenario was less about like what to enter on healthcare.gov and more about what questions are important to ask Benito in this scenario. So I want you guys to talk with your groups and discuss what information do you still need? What can you do with the information that you already have? Just figure out how this conversation needs to go, basically. Okay.
And what we'll do is, there's 3 groups, so we'll actually just divide this up and then we'll talk as a group about, you'll kind of present on each group. So this table over here, let's do you all as Benito, okay? Middle table, you'll be Alfreda. And then the back table will be Cassandra, okay? And these are all in your worksheets. And we want you, like Verena said, to go through, think about how this interaction needs to go, what information do you need to have? Maybe act it out, right? Practice it. What would you actually say? What are the words you would use? Sometimes that's so important to just practice how the words come out of your mouth. Because I'm going to say it a different way that feels really comfortable than Verena's going to say. And then we have some prompting questions. And if you all get stuck, we will come around and ask you all. Good? Better? Is someone moving from that table to this one? Okay, thank you. And if you've met someone new just now, say hi. Brayden, I'll share it with you.
Yeah. Yeah, so she still falls in that. I think she was- Yeah. Because it's 400%. So. Figure out her Is she above? She's falling in my shape. Yes. Like they said, you have to have Benito's here for March. What do you guys think? Oh, I mean, no, he's looking for when we.
applied in this scenario is exactly, so which one is, which special layer qualification is allowing you to check apply right now? Exactly. In most other cases, if someone comes with all these. Falling under one of those categories, it's like not open. So, yeah, the mark is a key point. We want to look at them. And then you guys already decided about dependence, their select or the supply options. You mentioned the smoking and then there are other ones too. So like, coverage to a job. Assuming that.
One thing I would look at is, you guys know if insurances are covered by.
No, so that wouldn't be the case here, because it's like self-employment, so yeah, he doesn't have any, I'm assuming, in his self-employment, any coverage associated with that, but I mean, you want to ask. It's like, I'm assuming with a small business coffee shop, but maybe if they own small company, that's the case. Would be very rare for our patient population, but yeah.
So then you would take this, and it's not.
Well, not necessarily, it's just something you need to ask, so the point of this exercise is to figure out what information we still need beneath our first. Yeah. And then, so this is a case where they have really specific preferences already, right? They're already coming in knowing what a silver plan is, they're saying they want those added savings. So this is where it becomes important to filter options on the marketplace, and filter results for claims, these types of things. Ricky mentioned prescriptions, definitely want to activate prescriptions, and make sure that the plans are done. Again, them not being super worried about the cost of premium usually isn't going to apply to our insured population, but these types of consumers do exist, so it's like a possible scenario.
Yes.
And then the other thing too is the way I basically start every encounter with a patient is like after I get an idea of why they want to talk to us, and talk more about it later. But after we're told, okay, this patient wants to talk to PCC, and we go in, one of the first questions I ask is like, how do you apply for the past? What is your experience? Because you can get like a lot of information. So in this case, we will get an idea of what is it about that previous plan in New York that they like. So we focus on that when looking for plans now. And maybe what was lacking, what like happened, and then also eligibility. You get a lot of people about eligibility. Because if they tell you, oh, I was enrolled in a health care plan in New York, like, that already gave you a lot of eligibility information. Probably they do fall under the range of things like that. So that's, if not like the second or like third question, like it's like somewhere in that beginning aspect of the conversation.
Do you guys want to like?
Tell me about it. And like Laura said, it's a conversation, like it's not like every month or like that has started has the steps, like what's the steps, like where there is no steps, you have to like go in very much like letting the patient guide the conversation. We need to know the key pieces of information that we want to get, but the conversation should flow naturally. There's no like flow chart that we follow, there's no like whatever, it's like a very natural conversation, which is hard to get used to at first and how you guys will start off doing it by yourselves, but yes, that's a part. Is there anything else?
Do you mind if I ask?
What's up?
And have a lot about yourself that is for mixed possibly, because you'll have either.
Yeah.
Something other than like angry.
That's particularly important to say, when we start talking about residency status.
Oh, really? Okay, let's look at it together then.
Like, it's always nice to.
Do you guys also have this?
Doing no age form, using that information about what.
We're not really public health.
Wait, I assume that means we have.
Like not just that, but also like in terms of like, so we were.
Yeah, so, cause that's
That's
Um,
where that is like your job is.
If someone
Because if you're able to get
definitely-
a short time your job.
Okay,
that's
I
that
thought
really
you meant like,
is- that's
people. I didn't think so.
No, yeah, that's the question he asked, yeah, so self-employed,
Yeah.
so when it's talking about employment for your job, it means like.
But if someone
I,
says like.
yes, I work for this company
Something about
offers health insurance through Blue Cross Blue Shield, I have Blue Cross Blue Shield, it's like a very specific, type of arrangement that I have. with companies that I work for. So if he's self-employed, we're making the assumption that he doesn't. Okay, let's.
Who do you have anybody to support, or you agree?
So most likely, the 8 out of 3, this would be the diagram.
They're not. It's grouping.
Yeah.
I know you told me.
Most usually one of those three elements, the ones that he's using, the
So
ones
maybe
that are
like.
covered.
Yeah.
Managing cholesterol. This is,
I don't.
this is, insulin probably is one of those 8. So the, yeah, the ones that are. The ones, but they have such a huge list. This is a good question though, because this comes up sometimes too. They're like, oh, I don't know what this is. I don't know. Like, all of this is very specific. They start to dose. Oh, I have no idea. We'll look at theirs. And for some of them are covered because it's time to find study, or if they remember something about their medication, and you can finally Google it to figure out what the best guess is. But yeah, you just want to enter like a bunch of them.
Another.
Yeah.
It's Medicaid, I believe.
But yeah, so for this example, obviously the ones that are 0 out of 3 don't cover it at all, maybe you wouldn't want to go for this plan.
Yeah.
But it looks like some of them do cover it.
Like every
So
single
it's
one
great
of
to have people. And good will also cover it. Prior expenses.
I've never been back.
Some years.
I've never heard of it.
So people will get like years of like emergency.
Yeah.
So it's great. to
Like I
have
said
people,
too, this whole,
having
It's a hard situation.
not, or he wasn't house, it was pretty much never.
where those money.
What income do you?
Which like,
Okay.
I guess, odds.
Is it right? I feel like it's going fast.
Right.
Just have this issue, I just want to go back. We, someone else. Background knowledge, maybe we're on that.
Yeah, that's extremely common. There is a lot of times where you look through every plan and nothing. In that case, you would go to plan type, if they're dental coverage and or is that looking for, go to plan type and then change that to dental plans.
How much?
And you would have to look through those options.
What was your household? So, to get ahead of some coverage.
No.
Or you're not.
Dental,
In some.
so, yeah, I would be careful with your verbiage there, because minimum essential coverage is referring to specifically plans that are allowed to be on the marketplace because of the importance of their act. That does not include dental coverage for adults. It includes it for children, but not for adults. So in that case, if they're interested in services beyond the minimum essential coverage, so they do want dental for adults, you would have to go look and buy those dental plans separately, because they're not part of the.
This plan here has vision. And coverage of 2,000.
I would really like to have really sad.
Do you have a specific?
Yeah, this is like.
But it's something that has.
So they want.
Another thing to
It
see
turns out like
is
they're
if
not
she has
coming in.
vision.
So it doesn't, where do you see that?
But also not the high insurance.
Yeah, eye care. So that would be more, that would be separate, that isn't indicated as right here on the pictures. That would be something where you're want to go to get something that could be good.
Says vision plus.
Oh, I
I have
see.
a question. At this point. Before,
So there's gonna be a bigger, with the expansion, like, yeah, you know, like qualified for Medicaid at this point. Would you mention that responsibility or not yet?
Yes, I would, as soon as she like gives her. Yes,
Yeah, so like you just narrowed down, you're like, hey, this seems like something that might be all I think you want. Your next step would be to pull up the summary of benefits right now. And go through this with them, to make sure that they understand. So they talk about items and research. We wanna find where it discusses that.
Okay, let's see, and a few more.
Okay, so you would come here.
We've never spent that.
You would have like this other jobs.
size is below that limit, then I would say.
Yes. I mean, but it's also exciting for the average person in our, well, I would never cover this. Yeah, but they also, to be honest, would usually be specific of requests based off that.
Yeah, they'll be smart.
Yeah, like in cases they don't worry about the.
And somebody, oh, will be like, oh, awesome.
No one has ever told me that they don't care what their premium costs. Most people just don't have the financial means to
They
care.
probably.
Yeah, exactly. So we're working on some free clinics, so we're
Yeah.
So, yeah, they're in perspective, you walk them through all of this, so they
very,
are
like,
exciting and make sure that they like these, like, don't come in and stuff. But yeah, that's, what you just went through, is like, you wouldn't say anything. That's not your job. Your job is to go the plan. This covers this and this, it's like, this is the deductible for premium, do you know what it's deductible, do you know what premium is? And then that's why give them some benefits, answer your questions.
I just don't understand like.
Not a lot. A lot of people like that are coming and they're uninsured and they,
Where they say they're
actually, we should never assume why they don't. That's where the question of why is important. If you're gonna have work a lot of times with people that aren't coming in being like, I want X, Y, and Z, it's like, oh, are you sure you have this in the first place? I don't have insurance, I'm just fine. And then that's like, they're rarely really be where they're coming in like, I need to make sure I have a silver plan, blah, blah, blah. But they will often have very specific health needs, so like the dental and eye stuff that you mentioned, it could be very true that actually they come in, not necessarily like, oh, I need a surgery or X, Y, and Z, but like, he can help me explore options for dental coverage, and that might not necessarily be the marketplace plan if they can't afford it, because like, the plan that you just showed, it will not be able to afford that, so that's when it would be like, do I need to submit a referral to check into go to our dental care, do I need to like have a support sliding scale places in the area, which we have a
Maybe they'll say,
doctor that
yeah,
outlines that.
so
So that's why we keep saying there's no like direct way that the conversations always go. It's like, it can go a lot of different places depending on the person's specific needs, so you just need to know what your resources are, where to find them. Yeah.
Yeah, do you have people who get trained? Low cost.
Yeah, it's a little-
coverage,
You can kind of pick up on
and then
what
buy
I say that just
potential
to.
if there's
Yeah, I mean, that's usually what it'll be. I mean, I haven't dealt with that many situations in the past, most of the healthcare.gov, I just, you're at my clinic and there hasn't been that many people that have to are super adamant about dental care. But if they were, that would be something that would explore, is like, okay, let's look at dental care, and see if these are affordable, and if not, the conversations that I was talking about, which is like, what other communities and resources can we utilize? Yeah.
How do you?
Good questions. What else is on your mind?
Like, shouldn't be done.
Healthcare expenses.
And once you guys get added,
And
some of these things that I'm referencing, you're probably like, where's this document where I can see all these like dental things like that. We have a thing in Microsoft Teams that you're gonna get added to once you finish training.
Oh, that's
And it has like this patient resources folder that's kind of like a hub that we've been like slowly building on. that lists like different community resources, for different types of.
Okay, so,
Different types of.
and it
people.
will.
'Cause We'll talk about this later, not all
You
of
have,
them, patients we deal with low income, a lot of them are
But you don't get any of
undocumented,
those
because a lot of
resources.
us talked about today, they wouldn't even be able to apply for it.
Right.
So.
And
Usually
so
they're like, just say,
when
oh,
people are eligible for Medicaid, you've already taken them. For
For
So we typically
And
have a dental plan.
you just say,
Oh,
oh, it goes up.
What was the second one?
Or
Like,
younger children.
It's kind of.
Yes, so.
There are these.
Right,
guys
you were
that don't
undocumented,
Like,
then you
That's not
cannot
how it
qualify
works.
for Medicaid.
like, there's just like, no.
If you are undocumented, you can qualify for something called the emergency Medicaid, which would cover the costs of very specific situations where something goes like really bad, you have like a heart attack, you're admitted to the emergency room, things like that, it'll cover those costs. But you can't apply for full Medicaid. if you're undocumented, and that's where things like UNC financial assistance are gonna be really important, which we spend an entire budget today covering. So I'm hoping we have time to go a little bit more in detail about the immigration stuff for Medicaid, because like I said, those are a lot of the people we work with. And now with the expansion, it used to be less relevant because not a lot of people fit all the Medicaid categories, but now that it's just an income thing, it's more important to understand the different immigration guidelines. So hopefully we have time to like go in depth, but if not, that's something we definitely should ask for about when it comes up, because the different like legally residing statuses, things like that can get a little bit. What was your original? Yeah, you're asking about.
I guess if they qualify.
Yeah. Unless they were born,
They might not already have them.
if you were born here, you, so there's something that you're applying with the chips, like, it's actually not all children anymore, it just means Medicaid for children. They're kind of getting rid of that kind of, it's just like Medicaid, but for children, that, if they were born by.
So regardless.
But when you're in mixed immigration status,
I
eligible,
don't know.
that,
Okay.
eligible for what, because it's not, just because the children are eligible for Medicaid doesn't mean
That's usually.
and not only being a citizen or legally residing resident first in the US, you have to do so for 5 years. before you come back.
Medicaid also offers transportation.
No. So children that were born here, you have citizenship, so that doesn't apply. But for the, say you just got a green card, but you've only had it for 3 years. So you've been legally residing.
Cause I just wanna feel like if they ask, I guess we could, so there's no options. The lottery is not exactly like they're doing, get lawfully present, but, like, and without a reason, explain their basic.
It's a very,
There are no options.
it's honestly, it's just
Are
a
there-
really.
yeah, are there options?
Yes, so the 5-year
It's
requirement does not have marketplace ones. And
What if they say
also
they don't want
UNC
to?
financial assistance doesn't do that at all. For people
Then I would
that
say.
would be able to get the care that they need in these facilities, that are undocumented, don't have any other, like, wouldn't qualify for any government subsidies, then, that's when we're like, we will talk really about today, because it's a lot of what we do is financial assistance, but you'll realize.
But like, I'm. There are absence of supply.
For who?
I've never run into that. I've never like.
You're.
And usually if someone is, then they'll ask them where they go wrong and they like.
Where you're saying for under 5 years, lawful residing, yes. Let me show you this document. Let me get my laptop.
I think it's like, so that.
Okay.
If you are expecting, we learned about this. If you're expecting to have a surgery or something, then you might be like, oh, I need health insurance, I need all that. And now it's just like.
Talk about all the immigration stuff.
So you would have actually where.
Sorry, I'm
This year I want.
give me 1 second.
Another thing with Medicaid, which off my head, there are like there are exceptions to having this. If you're locked.
Yes, yes. No, but I was
Oh,
really
you
curious.
were- Or.
Maybe, I think that's
Like,
yeah.
Cause we have seen.
There's some basic questions that are like.
Or like.
I like thinking about this. For pregnancy issues.
So I like. Yeah, it's gonna be hard to
We
like
can also get.
get into the nitty-gritty before you done.
It's like, courtesy stuff. So is our February. Okay.
And just like. Go
So
to
we're just talking about immigrant care, like.
If you approach it from a standpoint of like, oh, I.
So these are the statuses that the immigration services that we do. So when you get older, in this.
And it's also to remember too, like.
All of these ones are probably less common, those are the main ones.
Other
These
areas.
three, I think, are the most common that you'll see.
That might
Those
be
people, if they, that status for 5 years or longer, are eligible to apply.
Like mental health.
So most of these groups aren't really defined for period that I just described. There are some exceptions to that. If you're pregnant,
There's also
your child, so that's the exception as mentioned.
It's almost like, oh, I drove.
All for year, born year, they fall into that categories.
Or like other health.
Asylum refugee,
Where.
things like that. So this is where you would want to like reference these specific requirements before making eligibility applications. And then this is what I said, so if you're undocumented, okay, you don't meet any of those criteria. But you're still interested in applying to something like this, you would qualify for emergency Medicaid, which only covers things like heart attack, stroke, serious accident, and things like that. If you're pregnant, you also apply for like
And then-
pregnancy Medicaid, which is actually.
If
paid
operator
for
were
as
to
a child.
Safety net.
And you would apply for Medicaid as normal for any of these
30,000.
things, but this is instead of
How
full
would you
Medicaid,
guys
this is what you guys get it.
Like, do you?
And then,
Try to.
I mentioned some of these key points already, but like, you'll deal sometimes with mixed patients inside this household. Where some people will need, someone has asylum, another person doesn't have asylum. I've been in a situation before, like, they can get started on a Medicaid application, but their spouse, another spouse, like maybe their brother. or something. And then let's go to Marketplace specifically. Marketplace has the same list for legally residing pretty much as Medicaid. But they also have a few other categories that makes it kind of broader. So, you know, like non-immigrant visas, like, oh, if someone's like, hey, I'm on a work visa, I'm on a student visa, they wouldn't be eligible to apply for Medicaid, they would be eligible to explore Marketplace.
I think I'm.
Which you don't have to remember all the steps right now, but just, yeah, ask whoever's coordinating. it.
Yeah, I got it.
And you'll learn eventually too.
That's not really. Not about what we discussed.
Oh, yes, you're welcome.
Yeah, okay, so it looks like they qualify for a premium tax credit, which.
But it's just.
Essentially. Yes, it's about the. So this is in your monthly premium. Oh, so.
And if I buy a premium that's
apparently
less than this amount, do I get to opt for that? That'd be crazy.
Yeah.
That'd be awesome.
No, there would be so much. But after a year.
One of the, okay. Two extra.
Yes, that's right.
So, yeah,
You're undocumented. So,
Yes, we covered a lot of stuff.
Yeah, we covered a lot of stuff, yeah. Okay, let's come back together as a group and maybe share like 2 or 3 things you learned per group. Something that was specific to what you were talking about in your little cohort, in your table, and that we did not talk about already, something new that you learned. Who wants to start? Which group? Kendall?
We learned about pregnancy management and that the patient is trying to get pregnant, but it is retroactive.
Sorry, we'll just go to the case really quickly here. So Kendall's referring to this part right here where it says she also mentioned she is trying to get pregnant. So that's all the information we have at the moment.
Meaning that she replied.
Yeah.
That we would also consider if she wants to prioritize that for after.
One more thing.
And that we would need to know like her kids' ages, her marital status.
Okay, awesome. So you want to know her kid's age, her marital status, and her income. So those are questions that we would ask. Preferably open-ended questions is great. So however you can phrase that, everyone knows what an open-ended question is, right? So not a question that ends in someone saying yes or no, right? Where they have to say something additional. So can you tell me more about your family structure? How old are your kids? Are you married? Are you married is a yes or no question, but sometimes you can't avoid them. Tell me about your what you do outside of taking care of your kids. Do you work, etc. Yeah, but we talked about pregnancy Medicaid a lot at the end, and we were talking about it being retroactive, so people can apply up to a year after they're pregnant. Our organization has determined, kind of as a rule, that pregnancy is a really time-sensitive situation. It is something that we are not fully equipped to do. We are volunteers who work basically on Wednesdays, and that's about it, other than follow-ups. And we are just not the right people to be supporting patients to get coverage when they're pregnant. So as an organization, our kind of stance here is that you should always direct those situations to the health department. And you'll be working with your coordinator who has plenty of experience with what to do with these cases, but just to keep in mind that it's not something we'll handle. But just because, go ahead.
I was gonna say the health department actually, like I've just been learning more about what kind of prenatal services that they offer. But they can provide resources outside of just helping them seek coverage. Like they can provide actual care to like their prenatal clinics and things like that.
Yep.
So they're important to use as a resource for multiple reasons outside of just like
Yeah.
helping them with the application.
They could help them apply to WIC if that's relevant to women and infant and children services. And then, so we were talking about, well, if you're referring a patient to the health department, what is your role? Like, how do you continue to stay involved with this patient? Are you just kind of like, well, that's it. I have nothing else that I can offer in this situation. And the answer is no. There's still plenty that you can do to support as a volunteer. And there's things that we would want you to be involved in, such as helping the patient to get the phone number and the address for the health department, if that's what you all decide is the next step. Finding the health department that's closest to them, the one that they will be reaching out to. Offering to call with the patient, and you can do a conference call to the health department, just to either as moral support or to be someone else like an advocate on the call. You would decide with the patient beforehand how they want you to be involved in that conversation, but that's another way you can continue to support them. If they say, no, I'm good, I think I can call on my own tomorrow. I'll call, let's say Monday. I'll call on Monday on my own. You're like, great. Well, if it's okay with you, I think I'll check back in with you on Wednesday and see how that call went, right? And then you're giving some accountability. You're able to call back and say they're like, no, I got busy on Monday. It completely slipped my mind. You're like, no problem. Let's go ahead and see. Can we do maybe next Monday? I'm actually free during this time. Are you able to do that? I'd be happy to get on a call with you. So there's still ways that you can continue to be supportive. Be an advocate to help them get to where they need to go. Because our job is not just to help them with applications, it's really to navigate them to the next resource and warmly transition them off. Okay, good job, group 3. Anything else? Okay, scenario 2. You don't have to have one person share. Maybe you can split it up. Okay, great.
So kind of ran to look it up. Because, she actually, we asked her, about her housing, her family, she married, she had, then we had got her income and we're actually find out that she's covered by Medicaid. So if she wasn't covered by Medicaid, we were pretending she wasn't, that she had a higher income. And so then we asked her about her health history and her prescriptions and what she like.
I'm gonna let Annika guide you all, the group, through this conversation because you were sitting at this table. So if you want to come up and do that. But really quickly, I did want to add, so I love how you all were thinking like, okay, if it was Medicaid, then we're basically covered, but let's pretend it's not Medicaid and then think about these options. Like she wants to go UNC Health and she wants these prescriptions covered. We actually just learned recently, we had a Medicaid expansion conversation with a trainer in the state, and we learned about, what were they called? What were they called? We learned about managed care plans. Right? Is that what- Yeah, we learned about managed care plans, and managed care plans are basically like different insurance options under Medicaid. So it's kind of replicating, under Medicaid. So it's kind of replicating the marketplace in a way where there are options that people can pick. So it's actually also our job to help people figure out which managed care plan they're going to fit into. And managed care plans really matter because specialists are kind of located in certain areas. So based on where they're located in the state, maybe they want to go to one managed care plan versus another. So just something to think about though, but something we learned recently. Yeah.
And these managed care plans can have different sort of benefits, like some of them offer free like fitness facilities or other like random benefits like that. So the patient can just weigh the, that was not the right words, weigh the pros and cons of each like benefit for those plans. So we pretended that she made 30,000 once we realized that she qualified for Medicaid. And then what did you guys find out once we were trying with 30,000 instead of 18,000? Yeah, so she had, I think, $930 in premium tax credits. And then we, near the end, we're starting to compare those plans based on needing an in-home nurse, preferring UNC Home Health, and needing the 3 prescriptions covered, Vasitec, Detrol, and Humira. Yeah.
If she's a UNC patient and she's only making, can she get charity care as well?
You can't get charity care if you qualify for Medicaid, and Medicaid is more comprehensive than charity care. So it's just better for the patient in general to have Medicaid. Like all of her needs would be covered by that rather than charity care.
They've also rebranded and it is no longer referred to as charity care. So it's now UNC Financial Assistance. So like all of the online resources and everything, you would look up UNC Financial Assistance to find info. And that's also how we should be referring to it with patients, so that if they, wanted to look it up later, they know that it's called, like they're using the right term for it. So yeah, UNC Financial Assistance, which we will talk about in detail later.
Do you guys from scenario 2 have anything else to add?
We talked about like asking about like history with like health coverage, and then also asking about like recent medical expenses, because like you get like recent medical charges like paid off of it, either 3 months.
I believe 3 months.
Like
Medicaid has some retroactive coverage, and UNC Financial Assistance also, which we'll get into later, has retroactive coverage. So medical bills that you've built up in the past can be paid off by Medicaid or UNC Financial Assistance.
UNC Financial Assistance this is crazy. They'll pay your bills up for like 6, 10 years ago, which is not 3 months. So it's kind of interesting to know that. We've had plenty of patients who come in the clinic and they're like, I have this bill from 6 years ago when I gave birth, or I just major surgery, or had an accident, or something. And we're like, oh, well, let's see if we can get you applied to UC financial assistance. Maybe that bill will get taken off. And we've had plenty of success stories. We had one with $11,000 removed, one with $6,000 removed. From bills. Can you talk a little bit more about why you asked for previous healthcare coverages?
I think it was to see like what the patient like or just like what they have with their healthcare.
Okay, yeah.
And if they've previously applied for Medicaid and been denied in the past, that's a good way to figure out, like, hey, maybe they were in that childless adult category and previously before expansion didn't qualify for Medicaid, and now would be a good time to qualify post-expansion.
Or we also get an idea of, oh, so you're familiar with UNC financial systems, you've applied to that in the past. Okay, great. You want to try that again? Was that working for you? Or, oh, so you got on the marketplace for the last 15 years in a row? Well, great. What else can we help you with? You seem to have a lot of experience, but what is it that you'd like us to look at? So you get an idea from the patient. We were just talking to this people, like, a lot of our patients that we work with are going to have had health insurance for way longer than we've been alive. So acknowledge that our patients are coming into each interaction with us with a wide breadth of their own knowledge. And we come in with some knowledge as well. And the idea is that we're going to put it together to get the patient where they're trying to go, rather than being the final arbiters of all pieces of information. That is not our job. We will never get there. We don't want to have that attitude.
Right, scenario 1.
Okay, yeah, our conversation ended up going far past Benito. But do you guys want to say something that you learned with regards to this specific scenario? Something that we talked about, just to share with the group. Go ahead.
Because you specifically talked about diabetes, blood pressure, whatever, silver cost plans you pick covers insulin, like diabetes drug, and other prescriptions that Benito might use, and then let them know that they probably won't be back to
So yeah, so with the prescription drugs point, we talked about, do you want to explain what we talked about with when they're like, oh, I don't know what brand of drug I use. I don't know the frequency. I don't know the dosage. What did we say was like the best approach for handling that? Yeah, so yeah, and you don't have to like enter all 50 like he did, but we were talking about how there will be situations where they don't know exactly what it is. But you can just try and either put the best guess or like enter several to get an idea of whether or not that's going to be covered. So that's one thing that came up during our conversation. I'm trying to think of the other important points. And then can you guys talk about some of the questions that we still needed from Benito and Bert before we could decide how to move forward? Any of you?
We asked about dependents, smoking, do they have insurance for their jobs?
Yeah. There was also the question about like self-employment and that question about employment through your job. We discussed in the group how we can probably assume in the situation that for his small business coffee shop, he's not getting insurance through them. So yeah, that's kind of all the information that we still needed from them. Let's see. Do you guys want to share? Because we got into actually a conversation about immigration stuff. Do you guys want to share any insights from that conversation, even though it's not related to Benito? Yeah, go ahead. Well, yeah, yes. So, we were just talking about how it's a little bit more nuanced in that situation, and how we actually went through the slides from our monthly meeting where we were discussing immigrant care and the eligibility criteria, which we may or may not have time to like slightly touch on today. But how the marketplace, you're good. You're good. The marketplace Medicaid stuff that we've been discussing today sometimes doesn't apply to undocumented immigrants, and how we're going to have to explore other options and resources for them too. Yeah, that's pretty much it for Benito. Do you guys have anything else to add? Yes, thank you for bringing that up. Yeah, that one was important because they like we should have like a flag should have went up that been like, oh, that's outside of open enrollment period. Why does this work? What do they qualify for a special enrollment period? Any questions? Cool. All right, I guess into module 6.
Alrighty, so we will keep going now. I think you all are getting a really solid understanding. I'm really excited. I feel like you're asking good questions and really thinking, and makes me really happy. So we're gonna move on to module 6, which people who did get into their modules, how far have you gotten? 4, 3, 5, 3. Yeah, okay, that's what I figured. So half or less. And then how many people are still struggling to get into CMS? Few, okay. Yeah, more than a few, but okay. You talked about that we'll set up some office hours or something, okay. All right, so module 6 talks about vulnerable, this is the title that they've given, vulnerable and underserved. In the module, they're going to tell you that vulnerable is defined as high risk for multiple medical conditions, displaying fear and distrust in government programs and resources, having limited ability to give informed consent and be educated on available options, lack of transport, low capacity for communication, and facing discrimination. Whereas underserved, they classify as receiving fewer healthcare services, encountering barriers to primary care services, lacking familiarity with the healthcare services, and then facing a shortage of providers or services. So those are kind of the definitions that they've laid out for us. And I'm sure you can already point out some of the reasons why they've explained these definitions in the modules, and why they kind of want us to start thinking about these, about groups of people who may face challenges to receiving healthcare coverage. We are a good example of a clinic who receives a lot of patients who face challenges to receiving healthcare coverage. So definitely very relevant. But I do want to point out, does anyone notice any issues with using some of this language or the way that it's kind of framed? Yeah, Michelle. Mhm. Yeah, vulnerable can take away people's autonomy and independence in decision making. Anything else? Vulnerable is actually also a term that places the blame on the population who you've labeled as vulnerable, right? I know a lot of public health practices is kind of changing gears, and we're moving away from vulnerable to communities who are facing difficulties due to fill in the blank, discrimination, racism, environmental inequities, whatever the challenge is, but kind of restructuring why it is that the group of people you're referring to is having difficulties. Just something to think about. You're not going to have to write any essays in this. in our organization, but we do want you to be aware. And it's important because you'll meet people in the clinic who will come up to you and say, well, I have a very vulnerable patient. We need to talk to them. And you can restructure that. You can reframe that in favor of the patient. Let's see, what do we have here? So the term vulnerable is often used interchangeably with underserved. Yeah, this is a picture from the modules. So what they're trying to show here is that these two words get kind of confused sometimes, but even though there is considerable overlap, they're not the same as what they're trying to show us here. And actually, I'd rather go back to this slide and talk about underinsured versus uninsured, which are two terms we do use frequently in our clinic. And underinsured is kind of similar to underserved, where there are barriers to care, receiving fewer healthcare services, a shortage of providers, but not completely nothing. Whereas uninsured is not having any access to services for a variety of reasons. Okay, so you probably read in our mission that we support uninsured and underinsured. Okay, so great. So we've included this article from the Kaiser Foundation that talks about the role of social determinants of health in promoting health and health equity in healthcare systems. And they have this really wonderful chart that shows some of these social determinants of health. Does everyone know what a social determinant of health is? Yeah. And then now we're also recognizing that there are social determinants of health and there are also structural determinants of health. Does anyone have an idea what the difference could be?
Structural, like, more to like policies that are.
Mhm. Yeah. Exactly. Yeah. If you're in a spaghetti class, you're gonna hate me for a second here. But the socioecological model has 4 concentric circles, right? So we have the individual level. Can you see this? Or should I write over there? You can kind of see. Okay. You have the individual level. Then you have the interpersonal level or relational level. And you have environment. And then sometimes there's a third, another one that's like community or organizational. And then the last one is structural. Okay, so what is this chart really showing us? It's kind of, okay, so what this chart is trying to show us is that there are these different levels where factors can influence people, right? So what are some individual factors that you all can think of that might impact someone's ability to have access or use of healthcare coverage? What are some individual factors? Yeah.
They don't have a car.
They don't have a car? Okay, yeah, they don't have a car. That would actually fall